Nevada State Immunization Program was the staff around data modernization and ensuring that the WebIZ system is successful and accessible, and all of those really important activities. That is some of the staff that could be lost with COVID funding, and that's where we go back to the conversation earlier about what are some of that. If we were to get a sustainable general fund investment, what is some of the money the state would use? It would be for these larger data modernization projects, and where we do run the registry for the entire state, making sure it's robust and there's investment in there. If the CDC does not increase funding to the state immunization program, that type of staff may be lost.
No, I appreciate those comments. I think Nevada is not unique in experiencing these challenges. Many states, a lot of my colleagues of different chairs and members of HHS committees across the nation are understanding that this is a critical need that we're experiencing post-COVID. And so it's definitely something that we need to prioritize. And I actually really like the recommendation of reforming how nonprofits, if they do receive certain amount of funds, like what are the adequate training programs that they need to go through before they receive the funds, because at the end of the day, we do have the obligation to the taxpayers that we serve. So I appreciate your comments, and we look forward to keeping in touch. I don't know if there's any closing remarks.
Julia Peak, for the record, again, just thank you for your time, and we're happy to work with your staff if you want us to flesh out any of these policy recommendations or the research that Vicki alluded to. Happy to provide that to your staff.
Great, thank you so much. Let's go ahead and move on to agenda item. Give me 1 second just to comb through this. Let's move on to agenda item 9, which is a presentation on the state of Washington's expansion of healthcare coverage pursuant to the state innovation waiver under section 1332. With us, we actually have Ms. Joan Altman, who is the Director of Government Affairs and Strategic Partnerships from the Washington Health Benefit Exchange. She is joining us virtually, and she's going to provide to us about some of the innovative work that the state of Washington is doing for access to care. And so we'll go ahead and let her begin her presentation when she's ready.
Hi, Chair and members of the committee. Can everybody hear me okay?
Please proceed.
Great. I apologize to whoever is advancing slides for the fast talking. Thanks for inviting me. Hello from Washington, the other Washington. It's an honor to be here. I think we often look to your exchange and your state policymaking as a guide for where we want to go next and what we want to be doing. So it's a pleasure to speak with you all. I have been invited here today to talk about our 1332 waiver, which is the vehicle we used to extend coverage to people who are undocumented in Washington. The next slide shows you, actually, I'm not sure what you all are seeing, but there's a slide that shows you in terms of the topics for today, planning to cover the exchange, just orient you to where we are relative to your state, provide a little bit of background on the waiver, a little bit of outcomes that we've seen to date. We just launched it on November 1st. So we have some fresh numbers for you, and take any questions you may have about the launch or the process of getting the approval. So first, I wanted to step you through some exchange background. Under the Affordable Care Act, we were one of the first state-based marketplaces here in Washington. There are 19 now, which is pretty notable, and a significant difference I think we have from your exchange in Nevada is that we have an integrated platform. So people come to Health Plan Finder, we screen them for the available state programs first through our Medicaid, they're administered through our Medicaid agency. And then we screen them for available private coverage and the federal and the state subsidies. I have been at the exchange for 10 years. I'm a dinosaur here, so there's nothing you could ask that we could go back to the trove, but having a state-based marketplace, as you know, is a significant advantage as a state. So excited you all went that route as well. We are also we're a state-based marketplace and we're a public-private partnership. So we have our funding appropriated by the legislature. We have our board nominated by the legislature, and we adhere to certain state public disclosure laws, and otherwise we have a private side of how we operate that allows us to largely scale up and scale down contractually, and do some other private side hiring that has helped us along the way. Generally speaking, we serve about 2 million people through our exchange. Majority are Medicaid. It's about 2 million Medicaid customers and about 250,000 qualified health plan customers. We have robust carrier participation in Washington. It's 12 carriers. We've sustained active carrier participation for the duration of the exchange to date. So pleased about the competition that exists here in the market. Overall, we have seen the uninsured rate go from about 15% to about 4% here at the exchange. And let me drive slides. Hold, if you could hold for 1 second. Sorry, you all haven't been seeing those. Are you all able to see slides on screen?
Yep. Please proceed.
Great. Sorry about that. Wasn't sure I was driving, but here we are. Okay. So this is the first slides. You didn't miss much here in terms of visuals, just in terms of setting up for our marketplace. So we started around 14% uninsured before we did the Medicaid expansion and stood up the state-based marketplace under the Affordable Care Act. That number today sits around 4 or 5%. So have made some good gains. We've been focused largely on who's left. How can we look at access and affordability to further reach those who've been left out? To date, our individual market is small. It's about 5% of our overall insurance market. And there's about the 5% who are uninsured. Again, majority in Washington and employer-based coverage with a healthy dose of Medicaid and Medicare. So the legislature has kept us busy over the past few years. I'll say that we have been lucky in Washington. We have seen a series of major policy initiatives, but there has been sort of 2-year implementation windows as we have gone along the way, which has helped ensure that we are able to launch successfully. So the first thing that happened is in 2021, we implemented standard plans and public option plans in our exchange, collectively called Cascade Care plans. Then in 2023, we launched a state premium subsidy that sits on top of the federal subsidy or not, if you're someone who's not eligible for federal subsidies. And the third piece is the expansion to people who are undocumented under the 1332 waiver that we just launched for this year. So the initial Cascade Care legislation passed in 2019, we implemented in 2021, and then the state subsidy legislation passed in 21, and we implemented it in 23. At the same time the state premium subsidy legislation passed, there was authorization for us to seek the 1332 waiver, which we then did for 2024. So this is how it comes together in Washington. We have our standard plans that we design. We have the public option plans that our Medicaid agency procures, sort of leveraging their purchasing power for the state. And then we have the state subsidy that we administer here for people up to 250% of the federal poverty level. Again, it's connected to those Cascade Care plans. So you come in, you pick the high value, sort of lower premium plans, and then there's a state premium subsidy that sits on top of it. So I'll move into the waiver and the background for the waiver. Being undocumented in Washington is the strongest predictor of being uninsured in our state. We have right around 400,000 people who are uninsured in Washington, and about 100,000 are people who are undocumented. Being undocumented makes you 5 times more likely to be uninsured in Washington. So that was a driving force behind applying for the waiver. The goals of the exchange and the state in pursuing the waiver were simply to just ensure that anyone, regardless of immigration status, could buy health and dental insurance on the exchange, including accessing our Cascade Care plans. We wanted families with members of different immigration statuses, which we have several of in Washington, to be able to come through and buy health insurance together. We really wanted to maximize the privacy and the protections that we have built into our portal, the data safeguards. We wanted to leverage those in the process of expanding coverage. And we also wanted to strengthen Washington's healthcare sector. I think there was broad support for our waiver from providers and hospitals and nurses and labor and industry and carriers. We sort of had a lot of robust support for allowing people to come in and purchase coverage if they need it. Generally, the timeline, so we applied in May, it was approved in December. You can count the days. They have 180 days to review. It took 178. So it's a journey. We're hoping we were the first. So the hope would be any state that comes along behind us has a bit of a easier time. We waived the section of the ACA that prohibits people from applying for coverage based on their status. You are not able to waive the federal law that section of the Affordable Care Act that says people who are undocumented cannot receive federal subsidies. So any attempt that you all would make to address affordability barriers for people needs to sort of work around the fact that you don't get a federal subsidy, and that's not something that you as a state, at least as of today, have an ability to circumvent. We also privacy considerations were top of mind for people in our state. So we negotiated some extra privacy protections as part of our waiver negotiation that we've found quite useful. This slide shows you the waiver timeline. So again, legislation passed in spring of 21. We worked the application for a year, submitted that in the spring of 2022. As part of submitting your waiver, as you all know, you have a massive public comment requirement at the state level. Then there's a public comment period at the federal level. And then the feds ask you a bunch of highly technical questions. And then you're either approved or not. Concurrent to getting our approval, we started community engagement because we knew the runway. We had about a year from when it was approved to when we needed to implement, and laying the groundwork in community, developing the materials, translating materials, sort of finding trusted messengers in community to help get the word out were all really important parts of our launch. So we started the community engagement and then opened the doors November 1st, and people started receiving coverage in January. Some of the things we did to engage community, I think you just heard about some from the prior speaker, doing the listening sessions, doing the landscape scans, talking to impacted community members, really making funding available to do the education and outreach and to provide stipends to community-based organizations. Those were all things that we found helpful here in Washington. The top barriers that we knew we were going to have to address coming in based on the good community work that people had done in advance of the launch were, the number one reason was affordability and affordability barriers. The second was mistrust of government and government websites. And the third was health literacy and language access. So that is where we focused a lot of our efforts. From an affordability perspective, we're lucky to have the state premium subsidy in Washington. You can see that difference that it makes. It brings someone's premium, from just under $400 down to about $130. Majority of the people who've come in under the waiver to date are receiving state subsidies. So we know this has been critical to people being able to afford their coverage, even the lower cost public option plans. The privacy considerations, this was a multi-prong approach. So first, we were sort of active in working into our negotiation and our waiver documentation with the feds, assurances that only aggregate data would be required, and that what the uses of that data would be. Behind the scenes, we worked to sort of change forms and data transfer practices with the feds to eliminate kind of identifiers that could be used to identify people using and leveraging the waiver. And then internally, we did a lot of work on our data privacy policies, and updating internal policies and procedures that we use to sort of maximize someone's ability to meet the verifications and the requirements that are needed, but expanding the types of documentation and the types of materials that can be used to do that, to try to not help address those barriers as best we're able. And then from a language access perspective and a health literacy perspective, we were able to work with an agency here, the VITA agency, who's a multicultural marketing firm, who really helped us streamline and minimize our messaging. Health insurance is complicated. We do health literacy surveys, co-insurance, deductible. The terms and the acronyms become a lot very quickly, particularly if they're language barriers. So we really focused on sort of basics around health insurance and affordability, and basics around privacy and how information is used and not used when you enter it into our system. We also tried to work different formats. So we did our flyers and our brochures. We also did videos and print. We did some digital outreach. We did some local community art projects. We helped provide stipends to local organizations who went out and did in-language work and community-specific work across the state, both the east and the west side. So saw some important returns from the investments there as well. So that's it for the setup. What have we seen? So starting November 1st, everyone can come in and shop regardless of their immigration and income level. You can buy both a health plan and a dental plan. You can access the standard and the public option plans. And then if you're up to 250% of the federal poverty level, you receive a state subsidy. If you're federally subsidized, you get a subsidy up to $150 PMPM per member per month. And if you are non-federally subsidized, you get a state subsidy up to $250 PMPM. And the state looks at the legislative appropriation we get for that funding, the utilization of the federal and state subsidies across the population, and then calculates those amounts based on final rates. So here are the quick top lines. Of the 100,000 uninsured people in the state who are undocumented, so far, about a quarter of them, just over 24,000, have applied for health coverage since we launched the waiver. We were surprised by that number. That's a significant reach into the uninsured population, and we were just thankful to the work in partnership with our state agency partners and the community to really reach across all parts of the state. Less sort of good news, bad news. Lots of people could applied and were able to come into the system. 2,200 have signed up, meaning they've come in and they've made their first payment or they're in the process of making their first payment. And 90% of the people who've come in are receiving the state premium subsidy. So we know for over 250% of the federal poverty level, which is, just under $40,000 for a single household and $50,000 for a couple. We know significant affordability barriers remain for people who are over 250. And again, continuing to try to address that through levers like the public option and otherwise. The average monthly net premium for someone who's come in and signed up so far is just over $200 a month. Looking at the demographics and some of the folks who've come in so far, there's a lot of question at the federal level about what the risk profile would be of people who were coming in under the expansion. We see to date that our immigrant health coverage customers, only 7% of them are over 55, as opposed to 30% of our existing qualified health plan population. We also see significant diversity in who's come in. Over nearly 80% of the people who've come in so far identify as Hispanic, as compared to 14% of our overall QHP population, which is notable. We also see the number of non-white people who've come in through the system as significantly higher under the waiver as compared to our overall QHP population. Assisters matter. We have over 3,000 brokers and navigators who support outreach and enrollment for the exchange, and we saw nearly 70% of people who come into the waiver get help from someone local in their community. We also made language assistance available through our call center, but really having someone in community that you could go speak with who could help you enroll was critical. So looking ahead, where's Washington going? We're continuing to engage our impacted communities to sort of look at lessons learned and how we can improve and update materials heading into our next open enrollment period. We also have an ongoing special enrollment period for people who are eligible for the state subsidy, and which captures majority of people who've come in under the waiver to date. So we are waiting to see what attrition looks like and what our new enrollments look like as we move ahead. In the state of Washington, we're also doing a Medicaid expansion to people who are undocumented up to 138% of the federal poverty level. So that captures a good number of the people who came in and applied and didn't sign up under the waiver. So working in partnership with our Medicaid colleagues to look at how lessons learned from the qualified health plan expansion can inform the Medicaid expansion, how to transition folks over to that new program as needed, coming up later this summer. So I think that's the general background for me. You'll see in the appendix of your materials, I think you received some handouts too about our waiver and who's come in so far. There's some additional resources for your reference and some of the outreach materials that we used and some additional background on Cascade Care if it's of interest. My colleague Laura Kate Zeichkin is on and can help address questions as needed around Cascade Care. We have seen notable enrollment increases in both our standard and public option plans since we launched in 2021, with now about 70% of our exchange customers are in standard plans, and we've seen continuous growth in our public option plans as the downward pressure on premiums has made those plans the most affordable across the state. And that's it. I'll stop sharing there unless we want to keep the slides up for any reason, and happy to take any questions people may have.
Thank you so much for that presentation. We'll go ahead and start with questions. Committee members, I do ask for us to be respectful to our colleague from Washington. Hopefully we don't get into a political fight. She does have a lot of good insight in terms of healthcare delivery, so I just want to make sure that we're kind and respectful. So any questions down here in Southern Nevada? Slummy Min Win, and then we'll go to Dr. Owenlicker.
Thank you for your presentation. Just very quick question on my end. How many languages do you cover in terms of your in-language access? And if you don't have it on top of your head, it's okay. I just want to, that's kind of been my calling, and I wanted to see if I can benchmark Washington and raise the bar for our state.
That's high pressure. If our number's lower, then I'm not going to be able to help you. But we have a language line through our call center that we use. So we do telephonic interpretation through bilingual CSRs, and then we can translate into up to, I think, over 240 languages through our call center. And then for in-language translations, majority of our materials for this campaign, we translated into 15 languages. Typically, our standard in-language translations are in 8 languages.
Thank you so much. Dr. Owenlicker.
Thank you, Chair, and thank you for telling us about this. This is very, very interesting, and I hope we can follow along. So I'm interested in the slide where you talk about the subsidies. So my first 2 questions may ask the same thing. You mentioned after the state subsidies, the average premium is $210. So the combination question is, how do your subsidies compare to federal subsidies, and what would be the average premium if they just had the federal subsidies? So I think those are asking the same thing. And the other question, are you funding out of general revenues, or do you have a new dedicated funding source for this?
Yeah, those are great questions. Show me the money, right? Our average premium in the exchange is around $600, $550 to $600. So without any federal premium, that's where you're seeing, depending on our public option plans are a little bit lower cost. So the state subsidy is, for a frame of reference, Washington State is pulling down, I think now with the enhanced federal subsidies, close to $600–700 million a year in federal subsidies. The entire budget for annual budget for the state subsidy program is $55 million. And right now it's being funded out of general fund state revenues. We have engaged our legislature in thinking through, additional sustainable funding sources, looking at pass-through funding as it relates to our public option as a possible source there.
Yeah, so thank you for giving me on the gross amounts, but just on an individual who would pay, you said under your waiver, it's 200 a month?
Yeah,
person-
because of the
if that
lower
person-
income. Yep, sorry, go ahead.
So a person, same income, wasn't in this, was just in the regular and just getting federal subsidies, would they pay 210 a month or would they pay less than 210?
Oh, they would pay significantly less. Yeah, when you combine the federal advanced premium tax credits with our state subsidy for people who are under 250% of the federal poverty level, they can be getting plans for under $10, under $20. We see most low-income Washingtonians who are benefiting from both the federal subsidy and the state subsidy, paying less than $25 per member per month for their premium, as opposed to the 200, 250.
Okay, and so the federal only would be in what range? Just federal only subsidies?
The federal only subsidies would be, up to, it can really range based on where you live and your age and the benchmark plan in your county. So it's sort of a tough one. I can go back and look at the average, the sort of average premium price for our plans minus the subsidies, but I think it's bringing premiums down somewhere around, if our typical gross premium is somewhere between $500 and $600, the federal subsidy typically brings you down to somewhere in that $200 to $300 range, because then when you put the state subsidy on top of it, you're getting down to that $10, $20, $30 range,
Okay.
if that math makes sense.
Yeah, thank you.
Sure.
Thank you so much. Just a quick question for me. So based on my understanding, if I was, we can create a scenario. So I am a snowbird that is a Canadian and loves to come down to Washington during the summertime for whatever reason. God forbid something happens. I become ill. Something happens while I'm in the summer months in the United States. Obviously, I'm not a United States resident or a citizen because I'm only there temporarily vacationing. And so under the section waiver that you have for that person that is a non-citizen, if they become ill or if they wanted to purchase health insurance, they would be able to under the state of Washington. Is that correct?
Depends if they meet our residency requirement. So you do have to, under the Affordable Care Act and through the exchange, you do need to intend to reside in Washington. So I would need to look at the scenario where someone is kind of living part-time in one place and part-time somewhere else. To access coverage under the waiver, you would come in addition to, so you, as part of what the questions you answer when you come in, say, I live in Washington, and you complete the application and submit. And for people who live in Washington, they certainly could access coverage if they're willing and able to purchase it.
But the underlying premise is that they are residents and they live in that state, and so they're applying for the programming that they were not afforded to before, correct, under this
Yes.
program? And what are some of the challenges that you guys are experiencing as it showed, I'm assuming based on the slides, you presume there's about 100,000 of them. Obviously, it's difficult to enumerate how many of them are because of the different data provided from federal partners and what this actually looks like. And so it's hard to predict how many people are going to be enrolling. And so it sounded like about 1/5 of the population that you estimated immediately applied for once they became available last year. And then not all of them were able to come on. And so what are the challenges that you guys are experiencing as you're getting this influx of folks who finally have access to care, but we're still navigating them through the process?
Yeah, thanks, Chair. That's a great question. I think we're still learning. I would say incredibly early learnings from just having launched a few months ago. reach into all communities was not equal. So I think we really have relied on trusted community messengers in different pocket communities across the state. So we do know from looking at our early data, we had good representation among the people who applied, which we were pleased about. And then within the number of people who were able to afford to sign up, we saw less representation across some of the larger immigrant communities that we know exist in our state. So really figuring out how to make inroads and help people who can and want to get coverage, complete the application process and sign up is something that we're taking a close look at. I think we're continuing to look at ways that we could improve affordability as the primary barrier. From a privacy security standpoint, we feel like that 25% of people who are eligible came in was a pretty good indicator that we've helped address some of those fears, but continuing to learn and understand what additional efforts we may need to make to help people feel secure in providing all of the personal information and income information you need to complete an application under the ACA. So working in those areas, I would say most specifically, and then wanting to see the impact of the Medicaid expansion to see when you take away the price tag and when you sort of offer a free state program, what do you see as the uptake and how can that inform our efforts on the private side going forward?
Thank you, Ms. Altman. And just one final question from my side, and then I don't know if there's any members in Northern Nevada that have questions. I'm presuming that you completed an actuarial study that went alongside this waiver. Is that correct? I think you submitted that as one of the exhibits. And so, one of the questions that we always have is, if we expand access to care, are there potential savings that could be captured for these individuals who now will have healthcare access? Was that documented during it? And what are examples of those cost savings, perhaps?
Yeah, that's an excellent question. Still a little sore from the bruising in federal discussions on this one. But in the slide in the appendix, I included our projected waiver impacts. And again, we were pretty close on our enrollment projections. So we projected about 2,600 people would come in year one, and we got 2,200. So actual projection was pretty close there. Our actuaries and in partnership with our carriers, who also in commenting on the waiver had said they don't expect any adverse premium impacts. And if anything, they expected slight improvement in premiums as a result of expanding the risk pool. Our actuarial analysis found that for the small number of people that we would get, and then it would ramp up over the years, that there was about 2 million or so in savings, 2 to 3 million, at least initially, that we felt in the first few years we could draw down and recapture as pass-through savings for the state. Our federal partners felt that the existing data that exists nationally and the actuarial data we were able to provide demonstrated that we were able to meet federal guardrails and have the waiver be approved, but not enough that they weren't convinced enough to grant pass-through as part of our initial waiver application. So it's something they said they're open to revisiting with us in looking at possible combined pass-through savings from a public option and a coverage expansion. Those are things that we're sort of looking ahead to in years to come. But we think there's a little bit of savings there. Our carriers think there's a little bit of savings there. We'll get our federal partners, provide some additional data and help our federal partners get there, and then hopefully capture some pass-through that could help support additional state subsidies as needed to help address some of these affordability barriers. I'm manifesting here in front of you. We'll see if there are any federal partners listening to this, but appreciate the question. We're the first state to have a 1332 waiver approved as meeting guardrails, but we wanted to pass through and we didn't quite get there.
Thank you. And I know you're very early into the process, but there was some slight concern that when you expand access to care for some individuals, that can lead to, say, exacerbating provider shortages that we have. Has that been the case that you guys have had? Were there guardrails, or what's the relationship you have with your providers in terms of these individuals now receiving access to care?
Yeah, it's something we're going to continue to keep an eye on now that people have the coverage, what their experience accessing coverage looks like, both from the consumer and the provider perspective. We know from our Hospital Association, Nurses Association, Provider Association, Community Health Center Association, broad-based support for the waiver. And frankly, those providers are largely seeing people anyway in a clinic setting or an emergency room setting. So I don't think the opportunity to provide preventative care and primary care and sort of less invasive care earlier was welcomed largely by our provider community, as opposed to just seeing folks when they get sick or injured on the job. Or we have a lot of different agricultural professions and others that rely heavily on immigrant populations, and so folks were sort of seeing this population anyway and sort of welcoming of the opportunity to provide coverage in advance of some sort of adverse event.
Thank you. And it's my understanding that with risk pools, generally younger people are favorable just because we often don't get as sick. And so I'm assuming that a lot of the enrollments that you're seeing are around that same trajectory. I know you broke it down into 3 age groups, but are you seeing a high enrollment in kids or pregnant moms or individuals that are probably younger? Is that generally the trend that you're noticing?
Yeah, I appreciate that you said we, Chair, as young people, so I'll include myself in the category. I think we have some existing state-only programs, state-funded programs for pregnant women and CHIP kids. So we've seen uptake in those existing state programs prior to the waiver. But we are encouraged that in who we've seen come through so far, we do seem to be reaching the younger demographic more than we have reached them in our existing overall qualified health plan population. And so interested to see as we move forward, whether that continues to be the case or not, both for the 18 and younger, who are a healthy portion of the 0 to 34 age group I noted, and those sort of young invincibles who are sitting in that kind of 18 to 26 type category.
I'm sorry, I'm like getting like all these questions. And in terms of, have you seen any success stories with migrant workers now also being covered through this program? I know here in Nevada, we have a lot of migrant farm workers that get sick working on the fields and oftentimes have to rely on the free clinics that we have. And it's not as robust as it needs to be, right? Their diabetes goes uncontrolled. And so have you seen some success with migrant workers being able to finally access healthcare?
Yeah, I will know. We'll be following up with our sort of on the ground partners who work in these rural areas. Yakima farm workers and others have been sort of highly engaged in the effort. I will say, the Affordable Care Act can get inherently political, expansions can get inherently political, but in terms of bipartisan representation across the state, particularly in our rural areas, there's been a concerted effort to try to make sure that our farm workers, and we have, grapes, apples, lots of industries that the state relies on that lean heavily on farm workers and others who are benefiting from the waiver. So we are hoping to hear back from some of those partners as to the enrollment gains in particular sectors as we move forward. Too early to say from the data we have which sectors people have come from, but we know there was active engagement in our more rural areas, particularly around farm workers and agriculture, to help get people covered from industry and from our small employers and family farms who work most closely with those workers.
Great. Thank you so much. Anyone in Northern Nevada with any questions? Senator Titus, someone in gray?
Yes, please, Mr. Chair. First, thank you for
Go
the presentation. Always great to hear what other states are doing, especially similar with ag issues and migrant workers. And so, thank you for that. I want to follow up on a question that Vice Chair Unlicker asked regarding the monies and paying for these premium subsidies. There's a federal people, and then there's the state premium, but they're coming from your general fund, which is taxpayer funds, correct?
Yeah, we have, so at the federal level, the premium tax credits are coming, and that's subsidizing a majority of folks, then our general fund state dollars fund our existing Medicaid and our state premium subsidies. For the waiver, we had to designate the portion of the subsidies that would be supporting the waiver population. So of the approximately 55 million annually that the state provides to support the state premium subsidies, it's around 5 million of that that's designated to support the waiver population.
But it's all basic taxpayer funded, whether it's from the feds or the state. It's not industry funded at this point.
It's the exchange funding is a bit of a combination, but for our general fund state resources, then yeah, it's the state revenues that support that. We have a slightly different tax structure in Washington. We don't have an income tax here, but yes, generally speaking,
So
the state funded resources pay for it.
And you made on page 13 of your presentation, you said, it states that enables all Washingtonians to benefit from some of the state premium subsidies. So all Washingtonians can apply regardless of economic status, or how does that work?
Yeah, every person in the state who's a resident of Washington State can apply for health coverage through the exchange. And we have an integrated platform. So if you're at, designated income levels, lower income levels, you are eligible for the state programs, our Medicaid programs, including our, alien emergency medical and our CHIP programming and our postpartum and our pregnant women programs, and all of the sort of eligibility categories that have existed before the waiver. We still have today. And then what the waiver did was simply let someone who's not eligible for any of those Medicaid programs, who is eligible for private coverage through the exchange, to come in and purchase it.
Okay.
And then, as I mentioned, you don't get any federal subsidies, but you get a little bit of your state subsidy to help you.
And it lowered everybody's, you mentioned. Yeah,
if you're low income.
Yeah, and so the final question I have is, did you see? Is it too early to see yet? You said that maybe have lowered the premiums, but did your deductibles go up? Have you seen that yet?
It's interesting. Nothing. Yeah, it's a great question. We've been looking into deductibles and premium, particularly as it relates to our standard plans and our public options. So what we were able to do with the standard plans was, and most notably our public option plan, were create plans that have lower deductibles on average and lower premiums. So, and those plans that have the lower deductibles and the lower premiums are what the state premium subsidy is tied to. So if you come through our system and you pick one of these higher value, lower cost sort of state sponsored plans, then you get the state subsidy if you're income eligible, which helps you, afford that coverage and helps the state dollar stretch a little bit further.
Yeah, thank you for that, because I've been reading recent news that our own state employees' health insurance coverage premiums are going to be going up, and I'm just wondering how everybody fits this math in, and how does that work, where it seems like a win-win for everybody. So again, thank you for the presentation. Thank you, Mr. Chair.
Thank you, Senator Titus. Any other further questions? No? We'll go ahead and close this agenda item. Thank you so much, Ms. Altman. It's always a pleasure to have different states present about some of the innovative work that they're doing, and we greatly appreciate your time.
Thanks so much for having me. I look forward to what you all do next.
Thank you. And if you can, as you get more data points, if you can keep us in mind to share with the resources, we'd obviously greatly appreciate it. I do have a request to switch agenda items, so I am going to move on to agenda item 8, the overview of efforts and policy considerations to reduce food insecurity. So we're going to do agenda item 8, and then after that, we will do agenda item 7, which is a presentation on goals and objectives set forth for chronic disease prevention. So if our folks from agenda item 8, if you can please come forward. This is the one regarding food insecurity, and then please begin when you are ready. For committee members, we do have various different folks. We have folks from DHHS. We have Ms. Jenko from the chair of the Council for Food Security. We have DPBH represented, and of course, members of the Northern and Southern Nevada food banks and Three Square. So please begin when you're ready.
Good afternoon, Vicki Ives for the record, Bureau Chief, Child, Family, Community Wellness, and I'll be presenting with my colleagues Sarah Rogers, Deputy Bureau Chief of Division of Public and Behavioral Health. Thank you.
Hi, thank you. As Vicki mentioned, I'm Sarah Rogers, and I will be going over food insecurity for the Division of Public and Behavioral Health. An overview of what we're going over today. So as of 2021, the food insecurity rate in Nevada was up to 13% from 11% in 2020, higher than the national average, which is currently 10.4%. For race and ethnicity, the Black population is more likely to experience food insecurity at 21%, followed by Latino at 14%. And by congressional district, District 1 has the highest food insecurity rates at 17.8%, followed by District 4 at 13%, and then District 3 and District 2. There are many low access areas in Nevada, also known as food deserts, which are defined as areas with limited access to supermarkets or grocery stores, resulting in inadequate ability of nutritious and healthy foods within a 1-mile radius for urban areas and a 10-mile radius for rural areas per census tract. So the image on the left in the brown is highlighting all the low access areas in Nevada, and the image on the right is highlighting low access and low income areas in green. The Office of Food Security and Wellness falls under the Chronic Disease Prevention and Health Promotion section with NDPBH, and they manage the Funds for Healthy Nevada, or FHN Hunger Funds, which supports initiatives and programming aimed at reducing hunger, promoting public health, and improving health services. In addition, the Office of Food Security staffs a wellness component that supports they staff a wellness component, they support the Nevada's Governor's Council on Food Security, and they support the implementation of the 2023 strategic plan. FHN funds do support one state full-time staff, which is the Office of Food Security and Wellness Manager, in addition to $4 million per biennium for our food insecurity partners. For the 2024 to 2025 NOSA funding opportunity, we received 13 proposals for funding at a request that was almost double what we were able to provide. So in total, we were able to fund 11 partners at the $4 million. Additionally, the Office of Food Security has to supplement to be able to sustain all of their efforts, and they do so by using other federal grants that the Chronic Disease Program has, and they do this by funding a food security evaluator, wellness and prevention coordinator, and programming efforts underneath the wellness program. So the WIC program also falls within DPBH along with Office of Food Security, and they not only improve food security but also nutrition security. Just last month, Congress approved an additional $1 billion for the WIC program to be able to sustain the additional monthly allotment of cash value for fresh fruits and vegetables in the WIC package. It is estimated that 116,000 families in Nevada qualify for WIC. However, only about 50% of those families actually participate. SNAP participation for categorical eligible individuals makes them adjunctively eligible for WIC. However, this chart is showing that almost double the participation in SNAP. There's almost double the participation in SNAP versus WIC for those who are categorically and income eligible for WIC. Additionally, redemption rates are lower than we like to see them at 57% per month, and infant formula and fresh fruits and vegetables are the highest redeemed foods in the WIC package. So in order to efficiently support and improve food security across the state, the Office of Food Security needs to have the capacity and the ability to do so. The funds that support the office are not considered to be stable, and the FHN proposals are continuing to be much higher than the amounts we're able to provide, as costs for programs and costs for living for our FHN providers are continuing to increase. The Office of Food Security would benefit from additional staff members to improve technical assistance for community partners, be able to seek and apply for additional federal grants to help sustain the programs, and increase support for the Governor's Council on Food Security and continue implementation of the strategic plan. The state of Colorado has dedicated $14 million of supplemental funding to support initiatives that are very similar to our FHN Hunger Fund initiatives. Additionally, addressing barriers related to food deserts would increase the availability of adequate and quality foods to the most in need Nevadans. Illinois is seeking to address food deserts by supporting municipally owned grocery stores, and increasing client choice pantries in food deserts has also shown to increase access to fresh food options. Increasing participation in the WIC program is another important food security measure that DPBH and the Division of Welfare are currently working on. And I know Kelly from the Division of Welfare will speak a little bit more to that in the next few slides. It is important for healthcare providers to be knowledgeable of how to determine if a patient is food insecure by screening for hunger vital signs, and then how to effectively refer them to assistance. The WIC program is also making strides to modernize the WIC program through 2 federal grants, the Online Ordering Grant and a WIC Modernization Grant. And then that is it for DPBH's presentation. I know we have Kelly to go over SNAP. I don't know if we want to do questions prior, though.
Good afternoon. My name is Kelly Cantrell. I am Deputy Administrator with the Division of Welfare and Supportive Services. We're going to talk a little bit about life after the supplemental emergency allotment that ended as we started wrapping up COVID. So the first thing we want to talk about is a little bit about the partnership between SNAP and WIC. And caseworkers, our caseworkers are speaking to anybody with a child 5 and under to see if they have any interest in applying for WIC. So we do that with all of our interviews. And if they do have those children, we are doing an automatic referral over to the WIC. We email it over to the WIC when we have a person that's doing the interview with the eligible person. We also have customers that apply online through Access Nevada, and those individuals, if they indicate that they're interested in WIC, then that's an automatic referral that goes over. It doesn't require any intervention from our workers. And since the supplemental emergency allotment ended, we have seen an increase in the number of WIC referrals that we have. For anyone who may not know, the supplemental emergency allotments, basically what it did was anyone who's eligible for food stamps, if they were eligible for anything less than the full amount, it brought everyone up to the full benefit amount. So there was no one that was on benefits that didn't receive the full SNAP grant. Those benefits ended in February of 2023, and the last allotment went out in March of 2023. And we saw applications for SNAP increase, but only for that 1 month. And we did a lot of announcements. We did a lot of public service announcements. And so we think that the big push letting people know that these benefits were ending made our application counts go up. And so it's important to note here that from 2021 to 2022, there was a 22% increase in SNAP allotment. Does that match the inflation we've seen? Maybe not, but there has been quite a bit of increase. So just to put it in perspective, in 2020, at the end of 2020, because SNAP allotments go up in October of every year, so at the end of 2020, a single person was able to receive $204 in SNAP. In 2021, that jumped up to $250. It's one of the biggest increases we had ever seen in the SNAP program. And then today, that number is actually $291. So from today's allotment back to 2020's allotment, it's a 43% increase. Again, maybe not enough to fight inflation, but there has been a decent increase. If we turn over to the next slide, you can see that in March of 23, when the last supplemental emergency payments went out, we saw an uptick to about 50,000 SNAP applications in that 1 month, but then they kind of went right back down into that 45-ish range, and they continued to be right around in that range even today. Pre-pandemic, there were approximately 420,000 SNAP recipients on our rolls. And today we have over 500,000, so about 502,000, give or take, 502, 503, but we're at 500,000 individuals that are currently on the SNAP program. Pre-pandemic, the SNAP allotment that went out every month was about $48 million, and that allotment today is over $90 million. So you can see that increase, not only because of the people that were on assistance, but because of the increase in the actual allotment itself. And at the height of the pandemic, we were issuing $137 million every month in SNAP benefits to anyone that was eligible. So we'll flip to the next slide here, and you can see that when the SCA ended, we were taking an average of 1,000, we were sending an average of 1,000 electronic referrals over to WIC a month. And as soon as that ended, you can see here on the slide that average is about 1,400 a month now. So we're sending 1,400 a month. And these are just the automatic referrals that go through the online portal. These are not counting the number that my staff do when they're talking to people. So we're going to talk about a few things that we have in the works right now to reduce food insecurity in the coming next couple years, hopefully. The first thing that I'm really happy to announce is that we did apply for the waiver for the able-bodied adults without dependents that you probably heard a lot about recently. And Nevada is once again eligible for the waiver. So we do not have to put those rules into effect yet. We are good through June 30th of 2025. So we're going to keep applying for the waiver. It's kind of a double-edged sword because if we get it, that means our unemployment rates are higher than the rest of the states because we're just over 5% right now. But we don't have to lose people to the requirements that come with ABOD, which is the able-bodied adults without dependents. Another thing we're working on right now is we are requesting a waiver from Food and Nutrition Services to be able to take SNAP applications over the phone. Right now we don't do that because we don't have a mechanism to store the signature or the rights and obligations that our customers attest to. And so while we're working on that through IT, we are going to apply for the waiver so that we can take them over the phone in the interim until we can actually store that information. So that'll help a lot with individuals who can't get to the office, people who are disabled, elderly folks. I'm really glad that we're going to get that done, and hopefully that comes along here in the next few months. The next one is not always 100% popular with everyone, so just give me a minute here and I'll see if I can convince you. So we just started exploring participation in what's known as the restaurant meal program. And what the restaurant meal program does is it allows elderly, disabled, and unhoused individuals to use their SNAP benefits at local and participating restaurants. We know there's a lot of people who don't have a home or a place to cook food, and there's a lot of seniors who maybe can't cook, or disabled individuals who maybe can't cook for themselves. One of the reasons this program isn't as popular as you may think is because we've seen a lot of states roll this out with a lot of fast food restaurants participating. And so there's the argument that it's not healthy food. And so we've done some preliminary work over at DWSS, and we've spoke to a few restaurants. We started down in Clark County, and we spoke to a few restaurants to see what kind of restaurants we can get on board. And we're happy to report we've got interest from places like, this is a plug maybe, but from like Teriyaki Madness, who has like the vegetables and the food that's not like a fast food type food. And we've got others too. So we're really happy about that. UNR Extension reached out and indicated they would like to partner with us in speaking to restaurants that offer more nutritious options, and they actually have a list of the most nutritious restaurants in the state so that we can kind of work together to talk to those people once we get to a place where we're ready to roll this program out. So I'm kind of excited about that and curious to see how it goes, and I want Nevada to do it right. I don't just want to have all fast food, and we're hoping we can get other restaurants involved in that can give nutritious options to the community. We have, as Sarah stated, DWSS and WIC have started collaborating more to see if we can close that gap from the number of children on SNAP to the number of children on WIC that are eligible for both programs. And we started talking about co-locating folks who do eligibility for WIC into some of our welfare offices, so that if one of my workers say, hey, you're not eligible or you're over income for food stamps, maybe we can say, but WIC has a higher income limit and you can certainly subsidize with some of the benefits that they offer over here. We are creating a training to educate our staff better on what the WIC requirements are and what the income limits are. And we're going to make that training mandatory twice a year for all of the folks on my side of the house so that we can more effectively close that gap and make sure that all the children that are eligible receive the benefits from WIC. It's an amazing program, and we know, and there's been research done that shows the number one food item that WIC or that food stamps are spent on is formula. So if we could close that gap and say, hey, why don't you, if you could use WIC for a lot of that formula, then maybe you could use your SNAP benefits for other foods that you may need. Okay, and the last thing I want to talk to you guys about today is the summer EBT program. So as part of the Consolidated Appropriations Act, they launched the summer EBT program. It is a brand new program. The first benefits will go out for the summer of 2024. Now, because we just got the final interim rule in December of 23, we will not be able to get these benefits out before the school year ends this year, and they've allowed us to go until the end of September to get these benefits out. But what this is it provides grocery buying benefits to low-income families with school-aged children that lose that school lunch and school breakfast when they're not in school. And so they estimate that close to 30 million American children could benefit from SEBT, with potentially up to 350,000 of them being right here in the state of Nevada. And the summer EBT program, what it does is it provides $40 per month per child for the 3 months that they're out of school. And so that's $120 per eligible child during the summer months. And not this year, but starting in 2025, the requirement is that those benefits go out prior to the last day of school so that they're available on the card for the parents for use during the summer when those for your reduced school lunches are not available. We did submit our state plan to Food and Nutrition Services and our letter of intent to participate in the program. And we certainly look forward to rolling that out. It's a time crunch. We don't have a lot of time left to get it, but we're looking to have those benefits into families' hands by the end of September. And that's all I have today. Thank you.
Great, thank you. Let's take a quick pause to ask any questions. So just committee members, we can ask questions specifically to this presentation, and just know that the food banks, et cetera, will present after. So any questions? Let's go to Assemblyman Nguyen.
Thank you, Chair. I'm really excited to hear about that restaurant program, the local restaurant program, because I do think that definitely addresses if you're unhoused and you don't have access to a kitchen, or even you live in a room situation where you don't have access to anything that can cook those food, how are those restaurants be able to participate in the program, and to the requirements and I guess the reporting? How do you kind of monitor that right now to see if they are complying with whatever requirement, whether it's from the federal level or the state level?
Thank you for the question, Kelly Cantrell, for the record. So right now the program hasn't rolled out here in the state of Nevada, but the way it's going to work is restaurants will have to actually go to FNS, Food and Nutrition Services, and apply to become a participating restaurant. They will have to get the point of sale machines in their facilities so that individuals can use their EBT cards to pay for those bills. And so, believe it or not, DWSS will not have a lot of involvement in the monitoring of all of that. A lot of that is done directly. Like I said, we're in our infancy stages right now, so there's a lot of it that we don't know yet. But the more we know, I'm sure it'll be something that comes up down the road and I can have more information on, but today we're just starting.
Thank you, Ms. Cantrell. I think that's really something that I think could benefit both, not only the folks who are using it, but also the small business in districts all over Nevada. So I would love to stay engaged with that. So if you can help me to get connected to that, I would love to learn more about it. Thank you. Thank you, Chair.
Thank you. Just two questions for me, and then I'll go to Northern Nevada. You mentioned that there are a number of households that you would presume to be eligible for receiving WIC, but it's just that they're not applying. And perhaps I might be just misunderstanding. So there are households that meet the eligibility criteria that are asked if they would like to apply for WIC. Why not just use presumptive eligibility and enroll them into WIC? Is there something that federally you can't do, or do you need state authorization in order to do that?
Kelly Cantrell, for the record, I'm going to take a piece of this and kick it over to Ms. Rogers to answer the WIC side of that. So we if we identify someone, we could just send their information over to WIC. However, we did learn a while back that when we do that and they reach out to them, they say, well, we weren't interested in that, or we didn't ask for that. And we don't know why exactly, right? We just know that it works better if we ask the individual and they say, yes, I'm interested, and then we send the referral. That seems to work. I do believe there is categorical eligibility, though. If they're eligible for SNAP, Medicaid, or TANF, I do believe that they are automatically eligible for the WIC program. It's just a matter of getting them to apply, participate, and be willing to go through those motions on the other side.
Sarah Rogers for the record. Yeah, that's correct. So if someone is participating in SNAP, TANF, or Medicaid, they are adjunctively income eligible to apply or to participate in the WIC program. The WIC application is a separate process, so we do have different requirements in order to get them on the program. So we can deem them income eligible, but they would still need to make an appointment, come in. There's anthropometric measurements we need to take. There's iron that we need to take. We need to see them physically in the office. For the most part, there are some waivers now where we can see them over the phone or get anthropometric measurements faxed to a WIC clinic from the doctor's office. But it is just another step to actually get on the program and get set up with those WIC benefits, which is where we lose people all the time.
Yeah, my personal understanding of why you would encounter people who don't want to be registered is for two reasons. One, it's either a lack of education of what they receive from such program, or the stigmatization of such program saying, no, I'm good. I don't need this. I don't want to be affiliated with a government program that is termed as a safety net, right? That's not me. Not realizing that I could actually help them and they do qualify. It would be my perspective that we should enroll them regardless. They're meeting, as long as we have everything from our part in terms of the data requirements and they're eligible, right? Or we're presuming them to be eligible. Go ahead and enroll them, and then if they choose to disenroll, then that's up to them. That way we don't have any gaps and we can identify why people are disenrolling, whether it is of just not a clear understanding of what the program is. But I guess I would allude to it sounds like your teams are starting to merge and at least cross-train with one another so that you're not falling into the footsteps of folks being left behind because they don't know what the requirements are. The last question that I had was, piggyback off of the question on restaurants, I know one of the quotes that my public health professor had always told me when I was in undergrad was, there's always this question of, do we limit folks from purchasing chocolate bars or so forth in SNAP benefits? And I think in situations like this, we always forget the human aspect of folks that have to fall in these circumstances. So I commend you guys for looking at the restaurant program. I see this as an opportunity to support small businesses as well. Just as a quick question, are they able, currently under statute, are you able to go to farmers markets and use your SNAP benefits for that? Or for local farmers, is that also something that people can enroll in or participate in?
Kelly Cantrell for the record, yes. You can use your EBT card at participating farmers markets. We even had a veggie buck truck that rolled around at one point here in Nevada that also did that. I know we're getting ready to hear another presentation that will kind of lead into some of this. Double your food stamp bucks, and there's a program where if you use food stamps to buy produce, that you can actually double the amount. So if it was, say it's $1 a pound for apples and you buy a pound, you could actually get an additional pound for that same $1. So yes, you can.
Great, thank you. I don't think I have any others. Assemblywoman Brown-May.
Thank you, Chair. I do have one about the summer EBT program. I just want to make sure that we are really clear. Is this currently funded? It sounded like we are a done deal, but I believe I have an IFC agenda item for next week, and I just want to make sure that I understand really what's happening and what's necessary in order for us to fund this program.
Kelly Cantrell for the record. Thank you for the question. So what we have right now today, DWSS has enough to secure the contract with the vendor. And the IFC that we have on Friday, we are actually asking for authority to bring in the federal match for that portion. You will see us again at a later IFC and at a later BOE for more of that. So we are partially funded today, and so let me explain why. So a lot of this work is taking place in fiscal year 25. And so we're asking for 24 funding to start in 24, and then the benefits won't be issued until 25, so we have to come back and ask for 2025 funds to do, actually 2 summers will be done in fiscal year 2025, because we'll do 2024 in September of this year, and then May of next year, we should do summer of 25. So you will see us again. It's not 100% secured yet, but we have that plan, and we're on track, and be nice to us when we come ask.
Thank you for that. So do you have any idea, Ms. Cantrell, what is the dollar amount that's going to be asked for in each one of those? And I realize it's out into the future, but do you have any idea what's the total amount Nevada you anticipate is going to need to put up in order to draw down our federal match?
Kelly Cantrell for the record. So the total amount needed to administer summer of 2024 is 6 million, just over 6 million. And the total amount we need for summer of 2025 will be just over 8 million.
Thank you. Senator Tius, Assemblyman Gray, do you guys have any questions?
Yes, please. Thank you, Mr. Chair. So can we go back to page number four of your initial presentation on food insecurity? And I'm looking at the statistics on page number 4, and you talk about statewide percent of those that identify as food insecurity. And your last data field is really from 2021, and 2020 and 2021, those are just 2 spot years. I'm just wondering what it was pre-COVID, if you have those numbers, and if you don't, certainly could get them to us, because 2020 was certainly a unique point in time. Businesses shut down, jobs were lost, et cetera. 2021, we were not really fully recovered, and now here in 2024, a significant amount of improvement, we would hope, and especially with employment data that more people are working, et cetera. So I'd really be interested in seeing the numbers pre-COVID versus current data, the latest current data, say the 2023 data compared to what we're seeing at this spot here. Because it was a definitely skewed time in our lives.
Sarah Rogers for the record. Yeah, I can absolutely get that.
Great. Thank you. Thank you, Mr. Chair. That's the only question I had.
Thank you so much. Assemblyman Gray, did you have any questions?
Yes, sir. I've got a quick question for Ms. Cantrell. Ms. Cantrell, a lot of kids will be taking part in the summer programs through like Boys and Girls Clubs and things like that, so they won't necessarily be going without their lunchtime meal or whatnot. But is there a chance, or is there a way for any of these organizations to tap into funding, or maybe secure that EBT funding that would otherwise be going to the family, since they will be the ones picking up the slack?
Kelly Cantrell for the record. I don't believe there's any provision for that in the Consolidated Appropriations Act. If I may clarify something, Ms. Brown May, the totals I gave you were total state and federal. So state would be 50% of what I told you. As I was looking at my notes, I wanted to make sure that I got that back to you, 50% of that. Thank you.
Assemblyman, did you have any other further questions?
That's all, sir. Thank you.
Thank you so much. I don't think we have any questions, so we'll go ahead and close this presentation and move on to the next one. And I think it's Ms. Jenko who's next.
Good afternoon, Chair Jonyate and members of the committee. For the record, my name is Allison Jenko, and I am the Director of Nevada Government Relations for Dignity Health St. Rose Dominican. I also have the pleasure of serving as the Chair of the Governor's Council on Food Security. I'm here today to provide a quick history of the Council, an overview of our membership, an overview of the work the Council has done over the last couple of years, what we're looking to accomplish in the future, as well as a policy recommendation for this committee. Just some quick history. The Council on Food Security was established through an executive order by Governor Brian Sandoval in 2014 to implement the goals of the Food Security in Nevada plan and effectively improve the quality of life and health of Nevadans by increasing food security throughout the state. The council was then codified during the 80th legislative session. The Council on Food Security membership consists of a wide range of stakeholders, including individuals from the Nevada Department of Education, Catholic Charities, the U.S. Department of Agriculture, the Nevada Department of Agriculture, the Governor's Office of Economic Development, and so on. The council meets quarterly, along with special sessions, which help partners remain aware of various funding streams and assist with improving the quality of service and meals to Nevadans through education, recommendations, and feedback. I would be remiss if I did not thank the Office of Food Security, Ms. Lori Taylor, Ms. Sarah Rogers, and the Division of Public and Behavioral Health for supporting the council and being my right hand during council meetings. I would truly struggle without them, so thank you. The council is tasked with overseeing the implementation of the 2023 Food Security Strategic Plan, which was recently published by the Office of Food Security. We are also working to oversee the implementation of the goals in the Food Security Action Plan in the State Health Improvement Fund, which was presented to this committee by Megan Kamwasi with the UNR School of Public Health during the February meeting. The Food Security Strategic Plan demonstrates a continued commitment to lead conversations with a broad set of food security ecosystem stakeholders and create ideas to build the capacity of agencies tasked with this work. The pillars in the plan are designed to address the root causes of hunger and to generate a healthier food security ecosystem. This slide provides a quick overview of the food security pillars that are prescribed by the plan. And in the interest of time, I won't go through each pillar, but I just want to quickly highlight one pillar and give you an example of how these are used to inform the goals and objectives in the strategic plan and how the council is working to carry these out. So to emphasize lead, this is looking at enhanced cooperation, communication, and representation to support policy development and resource utilization. The objective under this is to improve collaboration, communication, coordination, and information sharing among food ecosystem partners. Our strategy under this goal and objective is to organize and host an annual food security summit and conference. Right now, the council has a work group that is putting together a survey to administer to food security partners and stakeholders. Right now, we're focusing on a Northern Food Security Conference to be held in 2025. So we're finalizing, we just actually got the draft for the survey today. So we're working on finalizing that survey, and then we'll be working on the details of that food security conference so we can bring folks together, talk about food security, figure out where we need to strategize, because our goals and priorities shift in food security. I think we're seeing this especially with COVID. Things are changing daily, and food security is just is an ever-flowing sort of subject. So and then next, the Food Security Conference will then move to Southern Nevada, and that will be held in 2027. So then we will then have another survey come out for those folks in Southern Nevada. So then we can focus on the area. For the other half of the state. So in terms of future goals for the council, in 2024, we're continuing to focus on education, the execution of the strategic plan, which if you have not had the opportunity to see the strategic plan, it is on the Office of Food Security website. It's incredibly robust. The team that put it together put really an eon's amount of work into it. It's very, very thorough, and I would encourage this committee to take a look at it. It's actually really impressive. And we, of course, are tasked with carrying out that strategic plan. So we are also tasked with carrying out the state improvement plan, food security action plan. In fact, one of the goals of that plan was to reach out to this committee and present, but you guys reached out to us, so we get to knock off that goal, so thank you for that. And then next is we're focusing our discussions and actions around distribution, support, and general food action, and then targeted collaboration with our state and local partners. Next, you'll hear from the food banks about the need for greater resources for the Home Feeds Nevada program, which was created through ARPA funding. But we're also looking at including more discussion around transportation to address food insecurity. So things are our conversations are very robust with the Council on Food Security. Like I said, we meet quarterly, but our meetings typically go hours. I'm a little biased. I think that we have a really great group of individuals on the council who are just a wealth of knowledge. And I'm really excited to see the work that comes out of our council in the next year, and looking forward to seeing what other legislation comes forward related to food insecurity and how the council can be, advocates for food security. And then just finally, our policy recommendation is the council is asking for 3 additional seats to be added to ensure that we have full representation of the communities that are served by our partners. We are asking for a tribal representative to be added to the council. We're also asking for an individual who represents the transportation industry. And then we're also asking for someone who has lived experience, so someone who has had used SNAP or has gotten has gone to the food banks and received those resources. So that's all I have for this committee. Here's my contact information, but thank you again so much for your time and asking me to present to this committee today.
Thank you. Let's go ahead and keep the presentations rolling, and then our committee members can ask all our presenters at the end regarding their questions. Let's go here in Southern Nevada.
Thank you, Mr. Chair. Beth Martino, President and CEO of 3 Square Food Bank. Appreciate the opportunity to share a little bit with you all today. My remarks, I thought I would focus a bit on what we are seeing as far as the face of food insecurity here in Southern Nevada, and then some of the policy issues that are, we think, of pressing importance, and I know a couple as well from Northern Nevada. So at 3 Square, we serve Clark, Lincoln, Esmeralda, and Nye counties, and last year, through our network of about 150 nonprofit community partners, we distributed more than 43 million pounds of food. We are on track this year to distribute even more than that to meet the rising need that we are seeing here in Southern Nevada. More than 140,000 unique individuals served through our network of partners. And what we know is that, getting people a meal when they're hungry is incredibly important, but we also are turning our attention very much to the work that allows people to become food secure and self-sufficient. And so looking for ways that we can enhance that work, and certainly one of those is through some of the supplemental nutrition programs that were mentioned today. As far as what we have seen in terms of need, as was mentioned earlier, with the expiration of some of the pandemic era benefits, specifically SNAP emergency allotments, but other programs as well, enhanced Medicaid access and other things, that has led to an increase in need here in Southern Nevada. Since last year, we have certainly seen through the data that we collect from our partners a rise in need. Most recently, from September through the end of February, we saw about a 23% increase. What's unique about what we see now in the data is not as much new people that are coming into food pantries, but people who were food insecure in the past are now becoming more repeat customers. They are finding that they are not able to stretch their dollar as far. And so you all, I am sure, have seen many of the same reports that we have about Nevada having the second highest grocery prices in the country. What we also know is that inflation has been a difficult pressure for consumers to absorb, particularly for those already living in poverty. Since the pandemic, so since 2020, grocery prices have risen on average 25%, and the categories in which those increases have been highest are beef, chicken, fruit, vegetables, and snacks. So some of the most core items in people's diets have become the most expensive for them to put on their tables. We also recently saw a report that for those earning minimum wage in Nevada, $11.25 an hour, potentially without health insurance, you would need to work 82 hours a week in order to afford a one-bedroom apartment. And so what we find is similar to a story I read over the weekend that was very frustrating about a family of four making $95,000 a year. She is an administrative assistant at a high school, and he is a machinist, and they simply can't stretch that budget far enough to keep food on the table. One medical bill sends them into a spiral, and she had a medical event herself, and they found that they were not able to make ends meet and had to come back to the food pantry for assistance. So as we're thinking about policy actions that might be able to help support some of that need, one of the things I wanted to mention today is summer EBT. We are very, at Three Square, and I'm sure Food Bank of Northern Nevada as well, very happy that the state opted into this program. What we know is that school breakfast and school lunch, as well as sometimes after school supper programs, are incredibly important for school children. For many, that is the way that they put food in their tummies all throughout the school year. And so we have other programs. A question was asked earlier about Boys and Girls Clubs and YMCAs. There is a program which Three Square operates called a Child and Adult Care Feeding Program that does provide meals to those sites. So in the summertime, Three Square provides tens of thousands of meals a week to those sites. But summer EBT is another way for kids who aren't able to access those programs, who can't make it to a Boys and Girls Club or a YMCA. What we hope is that the state will be able to make that match. That's the one of the hiccups, I guess I would say, that states are encountering. And if you look across the country, many states who opted into the program are trying to decide how they're going to come up with the funds to make that match. The good news is the bulk of the cost is being shouldered by the federal government. So the states only have to make the administrative match, which for Nevada is somewhere, as was said, in the neighborhood of $5 to $6 million. The second piece is then, of course, the administrative component and getting the word out to families so that they can participate in this. In states or in counties that may not already have a community eligibility provision where everyone is automatically enrolled in reduced or free lunches, there may be additional communication that needs to be done. There are enrollment processes, and so getting all of that underway is very important to help make that program successful. What we do know, fortunately, is that it is a successful program. It was piloted during the pandemic because we knew that children were missing school breakfast and school lunch, and so in a terrific public policy move, the federal government funded that program, and we found that it increased the amounts of fruits and vegetables that children were eating, and it increased food security. So there are a number of benefits to it. The second thing that we would really like to pursue in the next legislative session, again, is universal school meals. As you can tell, my theme here is that school breakfast and school lunch is an incredibly important component of keeping children well fed and nourished so that they can learn and ultimately live their best lives. And so having universal access to free school breakfast and school lunch is something that can make a very meaningful difference in the life of a child, but also to a family as a whole who may be struggling to put food food on the table. So expanding school meals to ensure that every child in the state of Nevada has access to a free school breakfast and school lunch would be incredibly meaningful, I think. So with that, I'm happy to defer to my colleagues in Northern Nevada. I would offer, just in closing, that for anyone who hasn't been to Three Square, we would love to host you anytime for a tour. I can tell you dozens of stories about the people that we serve, but one of the best ways to see what we do at Three Square specifically is to come and visit, and we'd be happy to host you anytime.
Thank you so much. Let's go ahead and move on to Northern Nevada.
Good morning. Well, I guess it's good afternoon. Nicole Lamboli, President and CEO, Food Bank of Northern Nevada. And so I'm not going to repeat a lot of the things that my colleague from Three Square said, except that we cover the remaining parts of the state. So we not only have urban sites, but we also have rural and frontier communities. Last year, we served about 19.2 million meals, just through our partnership of about 150 partner agencies as well. And the $2 million that was allocated for the first year of the biennium by this legislature was a significant investment, one of the first that we have seen by the legislature in supporting food purchase dollars. And that has allowed us to distribute nearly 1.7 million pounds of really high-quality, nutritious food because we've been able to purchase dairy and protein and fruits and vegetables, those items that people most desire. Over the course of the last year, we've seen about a 27.5% increase in the need. So today we're serving over 150,000 people per month. And just as Beth indicated, there are a number of factors, food prices, gas prices, housing prices, healthcare prices are all impacting families. And while there has been wage growth, there has not been enough wage growth to keep up with the rising costs. For a policy perspective, there's a couple things that we're really proud of as food banks. In the 2021 legislature, trying to remember, time has passed quickly, this body supported the Home Feeds Nevada food purchase program. And that was an intentional ask, working with people addressing food insecurity in the state, is to how could we create a program that would support almost like the federal commodities program, where we could support local food producers, manufacturers in supporting people facing food insecurity. And there was ARPA funding as well as, I think, local food purchase dollars through the USDA that were used to support that program. And it's been very successful. But we are coming back this next legislative session asking for continued funding of this program. It really is an economic development program. It's helping those farmers and food producers have a guaranteed source of funding to support their growing, their production, but also it keeps local foods here in the state supporting people facing food insecurity. So we look forward to working with this body in advancing funding for that as a policy priority and a funding opportunity. There are several programs throughout the country that represent food insecurity policy programs like Home Feeds Nevada. Secondly, we want to talk about the Section 1115 waivers, which would be a Medicaid waiver that would help support people facing food insecurity. Food and nutrition insecurity costs the U.S. an estimated $1.1 trillion annually in healthcare spending and lost productivity. We operate food pantry prescription programs, and we have the Fund for Healthy Nevada. There's too many HFNs and FHN programs. And so this, we've been operating these programs since 2016. And really, we are working with healthcare providers who identify people facing food insecurity. And then we have a network of pantry partners who are able to use that prescription to access healthy, nutritious food that meets their dietary needs. Oftentimes we see people who are facing food insecurity struggle at the end of the month when their funds run out, and then they are resorting to foods that may compromise their health condition. Through our prescription pantry programs, we actually have data that shows people who have diabetes combined with the right care, prescription medicine, prescription food, and diet and exercise have a better A1C level continuously because of the prescription food pantry. So we'd like to expand our work in helping improve the overall health of Nevadans by asking for the adoption of the Section 1115 Health-Related Social Needs Waiver. The state of Nevada has adopted a waiver related to housing supports, and so we think it would only be prudent to think about what that might look like for people who are burdened by food insecurity but also have chronic health conditions. Nutrition services are frequently tailored to health risk and designed to support individuals' specific nutrition-sensitive health conditions. But we think we can also do more for these individuals. If we can reduce the overall costs for people facing food insecurity related to their chronic health conditions, we believe that we will have a healthier Nevada. There are many states that are pursuing these 1115 waivers, and so this is something that many food banks are looking at, working with their states as a policy priority. With that, I'd be happy to answer any questions. Thank you.
Thank you so much. I think that concludes the presentations, and so we're ready from committee members to ask questions from all three. So let's go with Dr. Orenlicker and then Assemblywoman Brown-May.
Thank you, Chair, and thank you for the presentation. So I have two questions. One I think is a short one. I'll start with that. I like the idea of the 1115 waiver. Do you know if that whether HHS already has, our state HHS already has authority to apply, or we would need to authorize it legislatively? And then my second question, using food stamps, SNAP benefits for restaurants, I like that idea, people who don't have kitchens. And that made me think about the people living, unhoused people in the encampments who may also have difficulty preparing meals, may have difficulty going to restaurants. I know we have Meals on Wheels programs for seniors. You have a program like that. Are there also programs that take meals to these encampments to hand out there as well? Is that something that, is there a gap, or are we doing a good job there?
Chair Donyate, this is Allison Jenko. I can address the question about the 1115 waiver.
Please proceed.
Thank you, Assemblyman Orenlicker. To answer your question about the 1115 waiver, I don't know that the legislature would have to authorize Medicaid to move forward. I think that Medicaid has the authority, but Medicaid wouldn't necessarily have the money at this point to move forward with the 1115 waiver on their own. They may need legislative authority to have the money allocated to move forward with the waiver.
Thank you.
Thank you. And Ms. Martino, did you want to say something?
I'm Beth Martino, 3 Square for the record. As far as feeding individuals who are unhoused or in encampments, kind of separating that question into two parts, at least in terms of in Southern Nevada, what we do from 3 Square's perspective for individuals who are unhoused, who may not be able to prepare food or even access a restaurant. Many of our food pantries do offer ready-to-eat type items, and that's an important part of the food that we source. So that a really great example of that is food that we pick up from Starbucks that is still nutritious and perfectly good food for people to consume, but that the store is not going to sell. Those kind of things are ready to eat and are largely products that we try to get to the types of nonprofits that serve people who are unhoused or facing kind of that challenge. And we also have things like emergency bags that have just ready-to-eat food that have Pop-Tops or granola bars, things like that. In terms of going into the encampments to try to work with people specifically there are some organizations that we work with that do that kind of work. Help of Southern Nevada is one that they do have teams that go into the encampments to try to not just feed people, but also to do outreach to get folks interested in services. That is a much more difficult body of work for a variety of reasons. And I would say in terms of the people that we're serving, it's actually a smaller set of the neighbors that are served by, at least here in Southern Nevada, the food bank. What we find from our partners and what we hear through the data or see through the data that they report to us is that we're dealing with a lot more people that you would probably classify as working poor. Not as, there certainly is a large component to food insecurity that are individuals and families that may be unhoused or homeless, but I think a much greater proportion are actually people that are just working as hard as they can and not able to keep up.
Thank you. Assemblywoman Brown-May.
Thank you, Chair. Thank you. First, I want to double down on if you have not done a tour, please do so. As the chair of the Nonprofit Legislative Caucus, we've spent a bit of time working to understand what our nonprofit organizations are really doing to support our community. And so, Ms. Martino, we're completely aware here of what Three Square is doing. We look forward to going to our Northern Nevada Food Bank on Friday. So I would encourage members to consider that if they have not already. So thank you for what you do. My question is really relative to the Food Security Council membership. Ms. Janenko, you talked a little bit about what the recommendation is to add, I believe it was you, I apologize if I'm wrong, to add 3 slots, a tribal representative, an individual who represents transportation, and then one with lived experience. I'm curious to know, first, are all of the allocated positions filled for the current council membership? And then is there an odd number? Like, what will that do to voting if there's an action that comes out of that committee? Have we given thought to that?
Thank you for the question, Assemblywoman Brown-May. Allison Jenko for the record. To answer your question, no. Right now, we do have some vacancies on the council, and we are doing a little bit of musical chairs. We did have some folks expire. I believe we have, I think, 5 vacancies. I don't know off the top of my head, unfortunately, and I can get specifics to you. And as far as the full numbers, I don't know exact if it's an odd or an even number, but let me work on that and I will get it to you. I'm sure it's something we did consider, and we can definitely look at that. Thank you for flagging that for me, though. I appreciate it.
Thank you. I appreciate the detail relative to that. I would hope our people didn't expire, but their terms, perhaps.
Yes. Thank you. Thank you for clarifying that.
Thank you. That's all right. And I would just encourage perhaps a consideration for additional diversity so that we're representative of broader groups as we look to fill these out.
Yes, absolutely. Allison Jenko
Great.
for the record. Thank you.
Let's go to, I'm going to go to Northern Nevada in case of Dr. Titus or Assemblyman Gray have any questions. Seeing none, let's go back down here. Assemblyman Nguyen.
Thank you, Chair. And again, I'm going to triple down on what Assemblywoman Brown-May said. I volunteered for Three Square a few times in my days here in Las Vegas, and it's a lot of work. It's hard work. I think I felt really out of shape maybe 30 minutes into the packing and the putting things together for our community. So I do applaud your work, and I look forward to do the same thing in Northern Nevada. So look for me on the days to come to volunteer up there. So I encourage anyone that is watching or listening, please, if you can spare time, volunteer with Food Bank. I am kind of curious about, and I know that this work is always, there's so many things that you have to be able to cover, but just want to make sure the basics cover. You know, the API populations are the fastest growing in our state. You know, we have about 12% statewide of API residents. The basics of the API community are different. in terms of some of the food insecurity items that are out there. I just want to see, just curious on your, here in Southern and in terms of our Northern counterparts of some of the challenges that you may have in terms of serving this particular community.
Beth Martino, 3 Square for the record. Thank you for the question. It's something that's actually, I think, incredibly important body of work that we can do more on across the social safety net, but certainly within food banking. At 3 Square, one of the ways that we try to ensure we are well positioned to meet the needs of all of the different communities that we serve is by trying to source more raw ingredients as opposed to prepared items. So surprisingly, we actually have a fairly complex food sourcing plan because we look at everything from how do we serve people who are unhoused that need ready-to-eat type items to how do we serve different racial and ethnic communities. So, for example, we will have things like rice, beans, fruits, vegetables that we want to source as raw ingredients so that those can be distributed and then hopefully adapted to meet needs of the communities that we serve. So that is a large part of our sourcing strategy, and part of the reason why we look at it that way is so that we can try to adapt to meet those needs. I would say candidly, I think there is always more that we can do. And part of that is by ensuring that we are working very closely with our partners to find out who they are serving. That is a somewhat challenging issue. We never want to throw up more barriers to people getting access to food. So asking more questions inevitably leads to more people feeling reluctant to access services. And that's across the board from all of the programs that you've already heard about today. So we do actually have a questionnaire that our partners use when people are coming in for services. And it does ask for race and ethnicity because that helps us to learn more about who we're serving. But it's a very touchy and difficult issue because some people don't want to provide information to us. So that's really our first step in trying to get that information so that we can try to adjust that food sourcing plan to meet those needs. But would always be happy to provide some information to you about the makeup of the food that we're sourcing so that you could just have some window into what that looks like.
Any further questions? I just had a quick question. So I want to touch on the Universal School Meal Program. First and foremost, thank you for highlighting this as part of the proposal. I think it's important for us to have these discussions. Thinking back to like my personal experience. So I was one of the students that was on free and reduced lunch all throughout my life, actually. In middle school, I was reduced, but I actually had to pay. But then in high school, I was reduced, and because of the school population that I was in, I didn't have to pay anything, even though I was on reduced lunch. So it's interesting to see like just the different dynamics. I also want to preface that. So my own mother was a cafeteria manager. She was a lunch lady at an elementary school. And she would tell me about the stories of how it would break her heart where there were families that perhaps would qualify for free and reduced lunch, or for maybe they just didn't fill out the paperwork correctly and their kids didn't qualify for it. And they would have these balances accumulate, and because they had these balances, that she had to give them like a grilled cheese sandwich. And I think that's probably a story that still rings close to home for a lot of families. And it's kind of like this guilt that the poor kid that has this balance accumulate because their parents can't afford to pay it off now has to be stigmatized because they're the only one that gets the grilled cheese sandwich versus everyone else. And then there was also a consideration of, she would order these amounts of foods and some of it went to waste because she couldn't partner with the food banks and so forth. And so a lot of it had to go in the trash if she accounted for maybe 10, 15 extra meals. And so I think there's a lot of work that we need to do probably with universal school meals. For me, probably the most important is I know that a lot of the students that I went to school with probably would have benefited if there was a dinner program. And it sounds like we kind of had that, but it hasn't been as robust in terms of our partnerships. And so maybe if you can talk about what are the things that we can do to draw down more federal funds and coordinate with our schools, I think that would be helpful.
Thank you for the question and sharing your experience. Beth Martino, 3 Square for the record. Speaking for a moment to school lunch, I recall growing up in a rural area as a student and seeing at the time, I'm old enough that we still had punch cards, and the kids who were on free and reduced lunch had a different color punch card than everyone else, which is just heartbreaking because it only increases the stigma that already exists for those students. And so that's one of the benefits of universal school meals is that it really removes that stigma because everyone's getting the same thing. to the food waste issue, I think a very good question, and it's remarkable that people are so much more attentive to that now. It's one of the challenges of administering a federal program because they are very strict about what can be done with the food waste. So if, for example, all of the milk isn't consumed, it may have to be thrown away because of a federal regulation. So an example of something that may be actually coming from a good place and well-intended, but practically having to throw away good food is really a tragedy. In terms of dinner programs, yes, there is a program, CACFP, that I mentioned earlier that provides dinner. At 3 Square, we operate that program during the school year, and then we offer the corollary to it in the summer that provides breakfast and lunch, or that provides a lunch program. And during the school year until the 2021 school year, I believe, we provided that at CCSD sites, which would be the largest way to reach children after school. CCSD made the decision to bring that program internal and to operate it themselves. So they are providing a supper at a number of sites within the district. We've been in communication with them since they took that program over because we continue to operate it for non-CCSD sites. So we are at YMCAs and Boys and Girls Clubs. We've heard from both some sites as well as some after-school programs that some of the sites wondered if they could partner with us again because it was transitioned to a snack instead of a dinner. So we've just kind of tried to stay in communication with the school district here about that. And then we are providing in the rural areas shelf-stable after-school meals to try to fill that gap there as well at a number of sites. But I would agree with you. I think getting a meal to children in the afternoon, evening is a very important part of our work. We want to ensure with CCSD running that we're here to be supportive in every way that we can, hope that we can help support the sites that maybe have transitioned to snacks. And so we're staying in dialogue about that. And then looking for other sites around the city like libraries and Boys and Girls Clubs, YMCAs, any place like that we know children are going after school that we could help to feed them.
Yeah, thank you so much for those comments. I think, in your earlier presentation, you alluded to there are families out there that perhaps make too much to qualify for these programs, but not enough to support their families with the growing costs of groceries, rent, et cetera. And so it's always impactful to have these conversations in the policies that we pass. So I appreciate that sentiment. Ms. Janko, I think you had a clarification that you wanted to provide?
Yes, thank you, Chair Doñate. Assemblywoman Brown May, I was able to get an answer for you on the vacancies and the addition of the three members. Right now, the Council on Food Security has 5 vacancies, and with the addition of the three additional members, we would have 27 members. So, thank you.
Thank you so much. That concludes the questions for this presentation item, and we're going to go ahead and close it out and go on to our last agenda item, which is the presentation on Chronic Disease Prevention and Health Promotion Strategic Plan. Just as a reminder, we did budget 10 minutes for this presentation, so we'll go ahead and let the presenters present, and then if we have any questions and so forth. My goal is to finish by 4 o'clock, so hopefully we'll be there. And please proceed when you're ready.
Thank you, Sarah Rogers, again for the record, and I'm here with Vicki Ives, Bureau Chief for Bureau of Child, Family, and Community Wellness. And I did, going back to the last presentation, I did get the additional data points that Senator Titus requested, if it's okay if I go over those now for pre-COVID.
Please proceed.
So pre-COVID, so 2017, the food insecurity rate for the state of Nevada was 12.2. 2018, it was 12.8. Oh, sorry. So 2017, the food insecurity rate for the state was 12.2. 2018, it was 12.8%. And 2019, it was 12.1%, which did remind me that food insecurity actually did go down in 2020 just due to the increased resources that were available through the pandemic.
And if I might follow up, Mr. Chair, but you'll get the rest of those, like the congressional district ones from the 2018-19, and then the
I can get
20.
those too.
What I'm really interested in now is the rebound, the 22-23.
Yeah, okay.
Thank you. Thank you, Mr. Chair.
Okay.
Thank you,
sorry
Senator
about that.
Titus. Please proceed in the presentation.
Okay, so I'm going to go over the Chronic Disease Prevention and Health Promotion Strategic Plan. Instances of chronic disease is prevalent, with 6 in 10 adults having at least one chronic disease and 4 in 10 adults having at least 2 or more. As of 2021, Nevada is ranked 49th in dedicated state public health dollars at $14 per person, which I know Mr. Dick went over that with the addition of the SB 118. We're now at $19 per person, which is better, but still below where we would like to see to be able to use these funds to help mitigate and prevent chronic illnesses. So opportunities and challenges. From 2011 to 2021, 4 of the 5 leading causes of death in Nevada are from chronic disease. The onset of COVID-19 changed this trend. However, chronic disease deaths continue to rank high. In 2023, 18.8% of adults in Nevada reported a health status of fair or poor, which is an increase from 2022 at 17.9%. In 2021, 67% of Nevadans have overweight or obesity. Obesity rates have continued to rise, increasing from 24.5% in 2011 to 31.3% in 2021. And preliminary 2022 data is currently showing another increase to 33.5%. During the 2021-2022 school year, an estimated 33.1% of kindergarteners had overweight or obesity, which is an increase from the previous school year, which was 31.9%. Obesity is linked to the majority of new type 2 diabetes cases. In 2021, 11.3% of Nevadans had diagnosed diabetes. An additional 70,000 Nevadans have diabetes but do not know it, and 816,000 Nevadans have prediabetes. It is estimated that an additional 14,800 Nevadans will be diagnosed with diabetes annually. When it comes to tobacco use, it remains the leading cause of preventable death in the United States, and youth use of vapor products continues to increase. 44% of Nevada high school students have tried vaping products. 11% of Nevada adults currently smoke tobacco in some form. Nevada has an F ranking for the amount of funding invested in tobacco prevention and cessation. The Centers for Disease Control and Prevention recommends Nevada tobacco control program be funded at $30 million, and Nevada currently ranks 46 in state tobacco funding at $950,000. The financial burden of chronic disease is huge. The U.S. spends $4.3 trillion on healthcare, with 4% of that going to public health and prevention. Diagnosed diabetes costs an estimated $2.8 billion each year in Nevada alone, and obesity costs the U.S. $173 billion a year. Smoking-related illnesses cost over $300 billion in the United States per year. Contributing to the reduction of chronic disease will not only decrease the burden to the state, but also improve the financial burden to the state, but also improve the lives of Nevada individuals and their family. Primary prevention is key to preventing disease and improving long-term health outcomes, including quality of life. Primary prevention focuses on physical activity status, nutrition status, mental health and well-being, smoking status, and weight management. These are health behaviors that should be encouraged regardless of disease status to improve overall population health. While primary prevention is known to reduce instances of chronic disease and improve quality of life and overall health, there is no dedicated state funding for comprehensive wellness. Planning and policy. The purpose of the Chronic Disease Strategic Plan is to define specific and reasonable goals to reduce the burden of chronic disease in Nevada over the next 5 years and guide the work of the Chronic Disease Prevention and Health Promotion section within the Nevada Division of Public Behavioral Health. Over 40 state and local partners contributed to the plan. The plan looks to guide all agencies, nonprofits, governments, and communities working on chronic disease prevention. The overall vision is to achieve wellness for all Nevadans through the integration of primary prevention, health equity, useful data, evidence-based policy, and strong partnerships. The strategic goals are to expand evidence-based primary prevention efforts to reduce chronic disease across the lifespan, support efforts to improve health equity, generate timely data and information for action, support policies and promote wellness, strengthen partnerships and the capacity of our partners. Based on some top concerns related to chronic disease, we have compiled a list of some innovative policies and practices shown to reduce the burden of disease and improve overall wellness. Some innovative policies for tobacco control include curbing marketing on tobacco products. It is estimated that the tobacco industry will spend $75.3 million to market tobacco products in Nevada alone. Studies have shown that kids are twice as sensitive to tobacco advertisements and more influenced than peer pressure. Therefore, it is also important to increase the state's youth education and awareness on the dangers of cigarettes and e-cigarette use. Expanding the Nevada Clean Indoor Air Act to include workplaces and casinos can safeguard the health of Nevada workers from the harmful effects of secondhand smoke. Also, banning flavored cigarettes is an important policy that will protect youth, since 85% of the youth use flavored tobacco. Finally, expanding Nevada's preemption laws to include preemption on licensure, which would address regulations around over-the-counter tobacco sales and vending machines that include tobacco products. Additionally, support for statewide comprehensive wellness programs aimed at nutrition and physical activity promotion, education among providers, schools, school-age children, and their parents would be vital in primary prevention efforts and reduce or mitigate the impact of diet-related chronic illnesses. This includes the new statewide Healthy Eating Active Living program that the Chronic Disease just launched, which seeks to improve the discussions around eating more fruits and vegetables, reducing screen time, increasing activity, and consuming zero sugary beverages. Increasing the reach and impact of this program can include state focus on reducing sugar-sweetened beverages by reducing marketing and increasing promotion of other options. Increasing fruits and vegetables consumption can be done through education as well as support to low-income families by increasing the purchasing power of fruits and vegetables purchased through SNAP EBT through a Double Up Food Buck program. New York is an example of a state that has supported a Double Up Food Buck program, resulting in an overall increase of fresh fruits and vegetable sales. Wellness can also be promoted and achieved by improving nutrition and food security by increasing access to nutritious and affordable foods. This can be done by reducing the number of food deserts, improving and expanding participation in nutrition assistance programs like SNAP and WIC, school lunch and breakfast programs, and child and adult food care programs. Additionally, a focus on early cancer detection is vital to promote health. Behind skin cancer, breast cancer is the most common kind of new cancer in women. Black women have the highest mortality rate for breast cancer in Nevada. The Nevada Breast and Cervical Cancer Early Detection Program provides screenings for early detection and focusing on ensuring proper outreach is provided to Black women due to this increased risk in the state. This population has been hard to enhance screening efforts for, as they often do not qualify for the program due to insurance and income status. The program needs to increase capacity to further conduct outreach, increase screenings, and provide adequate referrals and follow-up to screening services they do qualify for. And I will take questions now.
Thank you so much. Committee members, any questions? Dr. Ornliger.
Yeah, I have two regarding tobacco. You described some very interesting, innovative policies on tobacco. And so my question about that is, are you bringing these to our attention, or are you endorsing them in your official role? And then the second question, those numbers about the cost of tobacco, $300 billion a year. You say, as you indicate, they dwarf costs from diabetes or obesity. Do we have any data on, as you pointed out, our current funding is 3% of what CDC recommends to control tobacco. Are there any data on the return on investment that if we went up another $1 million, $2 million, $5 million, how much that would reduce the costs of tobacco-related disease.
And I just want to preface really quickly on the first question. The agenda item that we have after this is specifically to the recommendations that folks present, and youth vaping is on that. So we will have more time to deliberate. But Ms. Rogers, please proceed.
Absolutely. Thank you, Sarah Rogers, for the record. So these are just policies that we're just bringing to your attention that other states have provided to help mitigate the effects of tobacco use. And as far as the data related to return on an investment, I can absolutely look for that and get back to you. I don't have those numbers with me.
Thank you.
Thank you. Any other questions from committee members? Assemblywoman Brown May.
Thank you, Chair. I have one specific to the reduced sugar sweetened beverage consumption, right? You say that we should support statewide comprehensive wellness program. Do you have like targeted measurements relative to the data, the amount of reduction you're trying to accomplish year over year? Is there a strategy that's currently in place or an education component relative to what sugar does to the human body?
Sarah Rogers for the record. So the Chronic Disease Prevention and Health Promotion section just launched a statewide healthy eating, active living program, which is also known as 5210. So 5 or more fruits and vegetables a day, 2 hours or less of screen time, 1 hour or more of physical activity, and 0 sugary beverages. So right now we're just in the preliminary stages of starting that campaign. We're focusing on just targeting healthcare providers and increasing messaging in clinics and with pediatricians specifically to talk to their patients. But we hope to expand the program to be able to be more encompassing of additional specific education. We would like to look at providing education and materials for schools, workplaces as well. So right now we're starting with the pediatricians and we're working with the health districts to promote to the pediatricians. We're also working with the Nevada chapter of Academy of Pediatrics as well. So it's just kind of the start, but ideally we would like a really robust wellness program out of this Healthy Eating, Active Living campaign.
Thank you. I appreciate that. I would just throw out there that potentially you would have an additional partner by moving toward autism groups or folks who have intellectual or developmental disabilities in that diet, and sugar intake in particular is seen to perhaps aggravate behavioral outbursts that may be characteristic to that diagnosis. So just something to help you navigate sort of that way as you work through the pediatrician's offices.
Thank you.
Thank you so much. Any other questions down here? Senator Titus or Assemblywoman Gray, do you guys have any questions?
More of a comment than a question. Thank you, Mr. Chair. And I would also encourage you to reach out as a primary care doc who saw a lot of kids and delivered kids. So don't ignore that, as I know we have a dearth of pediatricians in our state, and the primary care realm is fully covered with nurse practitioners, PAs, family physicians, and all of those folks too, to reach out if you're truly reaching out to all people, especially in rural areas. We certainly don't have any pediatricians, and the rural areas are very rare. So I would encourage you to put a little broader umbrella out there. Thank you. Thank you, Mr. Chair.
None at this time, Mr.
Assemblywoman
Chair.
Gray, did you have any questions?
Sorry, none at this time, sir.
Thank you, sir. Thank you. I think the only comment that I would have before concluding this presentation item and going to the last one is, I think there's some movement that we can, so with regard to reduced sugar sweetened beverages consumption and the consumption of non-healthy foods, there's certainly some amount of effort that us as a legislature can probably take on with what's being consumed by students at schools. It is to my knowledge that there are potentially loopholes where fundraisers are taking place, whether they're bringing in Jamba Juice or pizza or other types of vendors for fundraisers during the lunch period, right? And some schools have tried to navigate and try to hone in back on what students can purchase during the school hours. And so obviously there's much more that we can do to build that program and make it more diverse so that students can find the school meals appetizing. But I don't have any other questions. I think a lot of it is already covered and based on the policies that you recommended. So I appreciate all the sentiments, and of course we will take them for consideration as we develop our policy proposals. So any last minute questions? No? We'll go ahead and close this agenda item, and thank you so much, Ms. Rogers, for being here.
Thank you.
Last but not least, we do have, we've arrived to the last agenda item, which is agenda item X, 10, submitted policy recommendations to be reviewed by the Joint Interim Standing Committee. Just as a reminder to committee members, the way this agenda item works is we have had our survey opened to folks for recommendations. Committee members can submit their own recommendations to be reviewed by the committee, and then obviously we're soliciting feedback every day from folks in the community. We did receive a recommendation from Assemblyman Gray to look at the social work compact, and so we'll start with that one. We have a representative from CSG that will present virtually, and then after that, we did have a student that submitted a recommendation on a ban on flavored vaping products, and then our last one is cardiac event crisis response plans. And so we'll just allocate about 5 to 7 minutes for each presentation of them going over what their recommendations are, and then we can provide as members feedback or questions for them as we're going through them. So Assemblyman Gray, if you want to go ahead and proceed.
Thank you, Chair Donaire and committee members. I appreciate the time today. I'm joined by Matthew Schaefer and Nick Vanderpool. As we're all aware, there's a critical shortage of social workers in Nevada, a concern echoed by the Director of Health and Human Services during our recent meeting. In the 2023 legislative session, the minority party proposed an emergency bill for a social workers compact, recognizing the urgent need. Unfortunately, it didn't receive a hearing, possibly because the language was ahead of its time. However, since then, similar bills have been approved in 5 states, including our neighbor, Utah. I urge the committee to consider a bill draft request related to a social worker compact during the upcoming 2025 legislative session. Now I'd like to introduce Matthew Schaefer and Nick Vanderpool from the Council of State Governments for their insights on the compact.
Thank you, Assemblyman Gray.
Thank you, Assemblyman
For
Gray.
the record,
And to the chair and members of the committee, I'd just like to express my appreciation for your consideration of the Social Work Compact. My name's Matt Schaefer with the Council of State Governments. My remarks are meant to provide some background and educational information on the compact. CSG is a nonpartisan membership association for elected and appointed state government officials. CSG, through our National Center for Interstate Compacts, has facilitated the development process of all of the occupational licensing compacts that exist, including the 5 that Nevada has already enacted. That's the EMS Compact, Massage Therapy, Interstate Medical Licensure Compact, and the Psychology Compact. Nevada is also a member of 32 other compacts that are unrelated to professional licensing. So there's approximately 500,000 licensed social workers in the United States, and despite the high demand for social work services, licensees are currently limited to providing services within the state borders where they hold a license. The Social Work Compact seeks to provide licensees with opportunities for multi-state practice while supporting relocating practitioners and fostering workforce development by reducing unnecessary licensure burdens. The compact was created through a cooperative agreement between the Department of Defense and CSG. For the past 2 years, we've been developing the compact language with stakeholders from the profession, including the National Association of Social Workers, Association of Social Work Boards, and Social Work Regulatory Agency. The compact was finalized in February 3. So the compact will enable social workers to obtain what is known as a multi-state compact license issued by their home state that allows them to practice in every other part of the compact rather than have to obtain individual state-specific licenses in every state where they want to work. The Social Work Compact is very similar in form and function to the other licensure compacts that Nevada has already enacted. A social worker must hold an active unencumbered license in their home state to be eligible for a multi-state license. And licensees must also pass a background check and meet other eligibility criteria related to examinations and education. From a regulatory perspective, the compact preserves the authority of each member state to regulate practice within its state borders. A licensee practicing under a multi-state license must abide by all of the laws and rules where those services are being provided. and the Nevada Social Work Board has jurisdiction over anyone practicing in Nevada under a multi-state compact license. The compact benefits military families. If a military family gets assigned to a new duty station because of a basing decision, the service member or their spouse can continue to work on their multi-state license without needing to obtain a new license. Like all licensure compacts, the Social Work Compact will be governed by a commission made up of the member states, and that representative will be a delegate from the Nevada Social Work Board. As was mentioned, there are 5 member states currently, including Utah and Washington from the West, and there's currently pending legislation in 23 states for the 2024 session, including your neighboring state of Arizona. And last thing here, I would just like to note that this legislation is supported by the Nevada Social Work Board and the Nevada chapter of the National Association of Social Workers. So thank you for your time. I'd be happy to take any questions.
Thank you so much. Assemblyman Gray or Nick, did you guys have any other further comments?
Chair Donate and members of the committee, for the record, Nick Vanderpool with Flynn Judici Government Affairs. As stated, for me being here, my firm represents the Nevada Social Workers Board, and as Assemblyman Gray mentioned, the language was approved in February of 2023. It was a little ahead of its time, but since that time, as you've heard, across the country, there's a dire need for social workers and having the support of the board and the association. And as Director Whitley in your previous meeting alluded to, there's a high demand, and we believe this is a good solution for the social workers in Nevada. Thank you.
Thank you so much. Committee members, any questions or feedback for them? We don't have anything in Southern Nevada. Dr. Titus, did you have anything?
Yes, thank you, Mr. Chair. Just curious, especially for the Council of State Governments representative there. Recently, we had a discussion with multiple senators, assemblymen, and our governor regarding the need for professionals across the board in our states, especially in Nevada, not just social workers. But you mentioned yourself that we have 5 different compacts already. And the thought is actually to not chip away by doing these compacts, but instead actually look at a broader thought of actually doing reciprocity across the board for professional licensure. Is the Council of State Governments looking at anything like that? We know Arizona has passed a law along that regards, and instead of having this breakdown of every single professional thing and then still be behind, looking at just the state of Nevada doing reciprocity for professional licensures. Any thoughts towards that?
Sure. So I will note that Nevada does have what we call universal license recognition currently, which essentially says if you hold a license from another state and the board deems that the requirements that you satisfied to obtain that license in your other state, if those are substantially similar to Nevada, that they will issue you Nevada's version of that license. And so there is that already in place in Nevada, but I think the difference there between compacts and universal recognition is that compacts are really the only way where reciprocity is bi-directional. You're providing value for your current Nevada residents to go and work in other states or do telepractice or work temporarily in another state. And then you're also making it easier to attract people to Nevada who do not live in Nevada. So compacts are really the only way that we see where the reciprocity is bi-directional. Everything else that states are really looking at right now is just making it easier for people to either move or practice in their state, but not providing that same value for their current residents.
Thank you for that. Thank you for pointing out it's bi-directional with the with the compacts. I'm not so sure we want anybody leaving our state when it has a professional license. Just putting that out. No, but thank you for that clarification. Thank you, Mr. Chair.
Thank you. Any other feedback or questions? We'll go ahead and close this presentation and move on to the next one. Thank you so much to our representatives from CSG.
Thank you, Mr. Chair.
I would like to go ahead and call, Assemblyman Gray, is that you?
I just said thank you for the time.
Okay. Oh, thank you so much as well. Let's go on to so there was a recommendation of a moratorium on new hospice licenses. We will table this to the next agenda item, or the next time that we meet. We did receive from a couple of students here joining us today regarding a proposal to ban on flavored vaping products. We do have a few students with us, so please begin when you guys are ready.
Good afternoon to the members of the committee, and thank you for having us today. For the record, my name is Carissa Adamy, and I'm here with two of my peers, and we are respiratory therapy students at the College of Southern Nevada. We are due to graduate with our bachelor's degree in cardiorespiratory sciences in just a few weeks, and we have created an initiative called Flavor Free Nevada, which seeks to educate the youth and advocate for legislative changes to better benefit the community. And we are here to speak on agenda item 10. The rise in youth vaping and e-cigarette usage has become a significant public health concern in recent years, and in response in 2020, the FDA passed a national guidance enforcing restrictions on the sale of flavored e-cigarette cartridges, with the exception of tobacco and menthol flavors. This enforcement failed to address the sale of flavored disposable vapes, which can still easily be accessed at most retail stores here and are also the most widely used device among youth smokers. As previously mentioned, 44% of high schoolers in Nevada have tried vaping products. And in the most recent Nevada Youth Risk Behavior Survey, it reported that 47% of high schoolers felt it would be fairly easy or very easy to get electronic cigarettes.
Amira Ahmed for the record. So to address this public health issue, we recommend the committee consider implementing provisions on flavored electronic cigarette products to mitigate the rise of youth vaping. We propose prohibiting the sale of flavored disposable vapes with the exception of tobacco or menthol flavors, as well as capping the nicotine content in electronic nicotine delivery systems. We ask the committee to consider enacting legislation similar to Utah's SB 61, titled Electronic Cigarette Amendments. Some highlights of this bill include prohibiting the sale of e-cigarette products that have not received market authorization or are pending market authorization by the FDA. It codifies a nicotine limit on e-cigarette products and prohibits the sale of flavored e-cigarette products. Violation would result in civil penalty fines that would be allocated towards comprehensive drug programs, youth prevention, and cessation programs in Nevada.
For the record, my name is Maria Hurtado. Most legislations enacted in other states enforces a comprehensive flavor restriction on e-cigarette products, rather than targeting flavored disposable vapes. Our focus on restricting disposable flavor vapes seeks to find a balance between limiting youth access while also maintaining the availability of alternative options for current adult smokers. To safeguard the well-being of the youth, we advocate for imposing any limits on flavored e-cigarette products, whether it be a comprehensive flavor ban or just flavored disposable vapes. Thank you for your time, and thank you for the earlier questions on the youth tobacco use. Thank you.
Great, thank you so much. Committee members, do we have any questions or feedback? I must remind you, these are students, so let's take it easy on them. Dr. O?
Yeah, thank you, Chair, and thank you for bringing this forward. As you've indicated, this is a serious problem. This issue has come up in other settings where people have discussed it, and one of the views that some advocates hold is that you should ban all flavorings. The ones you're banning, you say tobacco flavor, okay, so I think people understand tobacco flavor, but they would also include menthol, and I notice you don't include menthol. So we appreciate your thoughts on why you would allow menthol flavoring, if I'm reading it correctly.
Thank you for your question. This is Carissa Adamy for the record. We chose to recommend keeping menthol and tobacco flavors to provide a alternative option for adult smokers because statistically youth smokers are more, they favor flavored vapes over tobacco and menthol flavors. I think if something like this were to be enacted, it would be important to define what flavor is. So if we follow suit to Utah, like we had recommended, it would define a flavored electronic cigarette product, which would include any taste or smell, fruit, chocolate, vanilla, honey, candy, cocoa, dessert, alcoholic beverages, herb or spice. So I just think clear language with that type of recommendation would be important.
Yeah, no, and your point about youth favoring other kinds of flavors, and I thought that, but when I looked it up a few months ago, I thought menthol was in the top 5 or 6 flavors for youth too. Maybe not as high as adults, but still in their top. Is that correct?
With the research I've done, it was mint flavors, so mint and menthol. I guess there's a difference with that. But we focused on banning flavored disposable vapes specifically, just so we can maintain options for adults like menthol or tobacco.
Thank you. And name for the record, please.
Carissa for the record.
Thank you. Any other questions or feedback? Senator Titus or Assemblyman Gray, do you guys have any feedback or questions?
Assemblyman Gray had to step out, and no, but thank you for presenting.
Thank you so much. It's interesting that this proposal is coming up, especially as other states are starting to tackle it. In your research, it is my understanding that some of the loopholes that are being exorbited by states that have passed this is there's still a black market that exists with illicit sales. Have you guys looked into that in terms of your research, or for instance, like if Chinese products obviously are not getting cleared by the FDA, but they're still being sold online, how the Attorney General's office or how the government can make sure that those products are still not being delivered to children? Have you guys done any research, or did that come up?
That did come up in Carissa Adamy for the record. That did come up within our research. Some states that have enacted similar policies, people will travel across state to get those products. With that, the recommendation would come from banning being able to purchase these products online. So as far as that, it would just be important with enforcement and policing of the policy.
Gotcha. And it sounds like to me, this is kind of like a two-pronged issue, right? One of it is what it sounds to me, right, when we think of public health, we think of the environment, we think of enforcement, and then the access to the certain product. And so this policy recommendation is more geared towards limiting the access part, since it's targeting more youth, and then figuring out what other products can be curtailed, for instance, in terms of advertising and so forth. Is that correct?
Carissa Adamy for the record, that's correct.
Just as a last question, what was your rationale? Why? I'm assuming this is your first time presenting in front of the legislature, so why did you guys think of submitting this policy recommendation, and why is it important for us to think about this further?
Carissa Adamy for the record. As respiratory therapy students, we spend a lot of time in hospitals and have seen firsthand the impact that smoking and tobacco use can cause with chronic issues and chronic disease. So we found that a lot of our problems as respiratory therapists deal with COPD patients, and just limiting access earlier on to a product that is more geared towards youth smokers would ultimately lower the availability and address a public health issue.
Thank you. And did all three of you go to school here in Nevada, I'm assuming? Yes. And was this something that you encountered through your own high school experiences of teen smoking, vaping products? Was that common, or is it more prevalent as you got older in college? Or if you can talk about your own personal experiences, that would be helpful.
Sure, Carissa Adamy for the record. For me personally, I am a little older than the products that were released. So vaping was not very prevalent when I was in high school, but when I went to college and everything, it's definitely more common. I have a younger brother who is in high school here, and he says it's very prevalent, and knew exactly about some of the products that I was talking to him about. So
Any other closing remarks or anything else you guys wanted to mention? Thank you so much for coming. We greatly appreciate it. And last but not least, we do have the last policy presentation item, which is cardiac event crisis response plans. And so we have a representative from Bells and Case Government Affairs. So please begin when you're ready.
Is that good to go south and north? Okay. Hello, Chair Dignate and committee. I'm Sabrina Schnur with Bells and Case Government Affairs on behalf of the American Heart Association. We appreciate the opportunity to provide a presentation on AHA's policy recommendation related to the adoption of CERPs, or Cardiac Emergency Response Plans, in Nevada schools. Cardiac arrest occurs when the heart malfunctions and stops beating unexpectedly. In seconds, a person becomes unresponsive and cannot breathe. Death occurs within minutes if the person does not receive treatment, but cardiac arrest can be reversible in some victims if it's treated quickly. Out of hospital cardiac arrest is associated with low survival. Approximately 70% of cardiac arrest occurs outside of a hospital setting, but early CPR and early defibrillation can improve outcomes. The correlation between a person's heart disease diagnosis and their increased risk for a heart attack lies in the progressive nature of coronary artery disease. People diagnosed with heart disease, especially those with significant narrowing of the coronary arteries, are at higher risk of experiencing a heart attack. So we can see here that Nevada has a higher percentage for people with heart disease, putting more Nevadans at risk. And then that Nevada graphic, those counties that are highlighted in that darker red, are Nye, Esmeralda, and Eureka. Chance of heart attack survival often lies in the hands of lay rescuers. Bystander CPR has been shown in multiple studies to improve out-of-hospital cardiac arrest survival and can double or triple the odds of survival. In schools with AEDs, approximately 70% of children survive cardiac arrest. That's 7 times the overall survival rate for children who experience cardiac arrest. And that's where cardiac emergency response plans, or CERPs, come in. A CERP is a written document that establishes specific steps to reduce death from cardiac arrest in school settings. A CERP can be a standalone document or part of a school's existing emergency response plans. When schools develop CERPs, it's important to work with local EMS providers to ensure the plan integrates with the community's EMS response protocol. A cardiac event can happen anywhere, and schools are a nucleus for a variety of events in all communities. In 2022, Nevada had 447,603 students and 23,557 teachers in schools. And it's important for school facilities to have a plan in place to address cardiac arrest. It's estimated that in the U.S., there are more than 23,000 children under the age of 18 who experience cardiac arrest outside of a hospital each year. Only 40% of those are sports-related. AHA recommends implementing emergency response plans for cardiac and other medical events in schools. CRPs double the survival rate of cardiac arrests, and there should be a CERP in every school. So our ask, the American Heart Association recommends that Nevada schools adopt CERPs as part of their existing emergency response plans that are already outlined in NRS 388. You'll see on the document we submitted a typo in the recommendation section that reads health districts, where it should read school districts. I clearly had Public Health Day on my mind. The legislature can be prescriptive in what should be included in CERPs, or the legislature can leave it up to the school district to determine what their CERP needs to include. The AHA has guidelines that can be provided regarding what CERP should include. This statutory change would just require the schools to do the emergency response planning. I would also direct the committee's attention to the CERP FAQ flyer that we've provided to LCB staff for additional information. And that concludes my presentation. I would gladly take any questions.
Thank you so much. Committee members, any questions or feedback? I don't see anything down here. Anything in Northern Nevada? Seeing none. All right. We appreciate your presentation, and we'll go ahead and close it out. Again, As I stated, the committee will have a recapture of all the recommendations that were submitted, and we'll have further discussion as we get towards the end of the interim. We'll go ahead and close out this agenda item, and we'll move on to our last one, which is public comment. Is there anyone here in Southern Nevada or in Northern Nevada that would like to provide public comment? Please come forward. We'll start here in Las Vegas. Please proceed.
Thank you, Leanne McAllister, Executive Director of the Nevada chapter of the American Academy of Pediatrics. I want to stand in strong support of banning flavors as presented by the students who came earlier today. And I wanted to read a quote from Dr. Sandy Chung, who is the president of the American Academy of Pediatrics in 2023. Menthol cigarettes and flavored cigarettes are designed and marketed to addict children, plain and simple. Thank you very much.
Good afternoon. I'm not with my herd that was here first thing in the morning. I'm Lorraine Oliver. I'm an employee, past employee of Southern Nevada Health District. I'm here because I'd like to provide you with some context on some of the stuff that you folks raised and questions that you raised, not only with the people who are in charge of us at the Health District. I'm a retiree. I'm a nurse that worked there until 2020, and then I went back for the efforts regarding MPOX, which is the polite way of saying it these days, and COVID. And I also helped in their sexual health clinic. Just so you know, from the perspective of the employees, not the management, we did not really want them to have what we thought would take away from public health when they said they wanted to have the FQHC. Not that we didn't think an FQHC was something good to have in the community if we have inadequate services for people, but that we thought it would take away from what public health's mission was. And we still have many questions about that. I think it was demonstrated quite clearly to you folks in your various comments from the management this morning that they're not in the habit of talking to employees and asking for their input, and that is a sad commentary of us. This morning, some of the staff here were almost in tears when they heard those comments. There was other things that we think maybe you should ask. It is not that we don't want the funding, and it is not that we want you to fight for us as workers in the sense of us fighting at the moment in a contract. It's that we definitely felt completely slighted in the way we were treated throughout this time period, really, even prior to COVID. We took zero pay cuts at times just to make sure that the health department stayed functional. And so what I would ask if I was you folks is and a picture of what have you done for your employees in this time frame. That'll give you a picture of saying that we're not just the greedy workers. The second thing is that what they did, while other people were doing significant stuff for their frontline staffers, they did things like taco trucks and ice cream sundaes and things like that, which don't help your bottom line. You heard a lot of comments from some of my coworkers, and I'll wrap up. You heard a lot of comments from some of my coworkers where they're about to try doing some takeaways. They're going to take away help for their vehicles. They want to take away, as for money, they're offering us like 2%, which is not even beginning to catch up with what the markets have been doing and what we're going through financially. I appreciate your time. My name is Lorraine Oliver. I'm a retired nurse, willing to work. I might have to go to Carson City where they're looking for nurses.
Thank you so much, and thank you for your years of service. Anyone else in Las Vegas? Seeing none here. Anyone in Carson City? VPS, anyone virtually?
Chair, the public line is open and working, but we have no callers at this time.
Thank you so much. We'll go ahead and close public comment. Our next two meetings are going to be specifically on behavioral health. The one in May will be focused on adult behavioral health, and then the one in June will be on children's behavioral health. So we have a lot of work to get done, but I appreciate everyone for participating today, and we'll go ahead and close this meeting. Meeting is now officially adjourned.
Thank you, Mr. Chair.